So, good morning, everybody. We are going to begin this session. I want to welcome you all, my friends. It's good to be here with you. It would be better to be in different conditions, but that's what we have by the moment. What have I done? I lost you. Ó Diogo, ajude-me aqui, faz favor. Que eu acho que desliguei a sessão, a coisa que o valha, porque isto não ser o nosso computador perturba um bocadinho. Ok. Mas não posso retirar aqui esta parte para ver a galeria completa. Okay. Right. So I was saying that it's a pleasure to have you here. We are going for the session that will be supposedly the last one in our master class. It has been a somehow troubleshooting course because of the COVID pandemic, you know. Anyway, we're going to try to finish it and hope to meet you all in Naples soon in the end of the activity. Hopefully this session can be interesting. It's about revisional surgery. We are going to perform a surgery, a conversion from sleeve to OAGB. After that, we are going to have some two talks and some discussion that I hope it can be also fruitful for all of you. Meanwhile, I suppose everybody knows me. I am Rui Ribeiro. I work in Lisbon in this clinic. This is a small hospital now with 110 active beds. I'm in the field of bariatric and metabolic surgery for 20 years, and really OHB is my mainstream operation since 2010. So we have an experience about more than 2,700 bariatric surgeries, and we are going to discuss with you with a big pleasure the issues about this technique. Telling you about what we do and our team. We have a complete multidisciplinary team with all the participants, nutritionists, psychologists, physiotherapists, endocrinologists, internal medicine, and dedicated anesthesiologists also in the OR, as well as dedicated nurses. So it's about 20 people. And we are performing not a big number of cases because it's a completely private hospital. We operated last year 150 cases, most of them OAGB. Clinica Sant Antonio is a small hospital in the outskirts of Lisbon, in a city which it's called Amadora. Some of you have been here already, so they know you know what I am talking. We have now 10 ORs. We increased a little bit because of the increasing demanding. We have ICU, a new recovery room for 10 patients. We have an emergency department open 24 hours a day, which is a very important factor because our patients have also the chance to come up to here when they are not good or they are not comfortable, at least with their clinical condition. What we have also good here is an important maternity with an important volume of deliveries and also a nice modern techniques for that. And also an oncologic center with all the valencies and including a radiotherapy department that is providing service to the in outsourcing for other hospitals. And it is the center for the radiotherapy in the Lusíadas group, which is part of the UGH, which I'll tell you about that later on. Our center is called Centro Multidisciplinar de Doença Metabólica. It means multidisciplinary center for metabolic disease. It means that we are not only focused about obesity, but we are also focused about metabolic diseases, mainly diabetes, as you know. Lusíadas Group is based in an hospital that was founded 12 years ago in Lisbon. That was a new and bigger hospital near us. that is in Lisbon, near the Benfica Stadium, by the way. And at that time, it was property of a Portuguese bank that was later on sold to a Brazilian company, the bigger health company in Brazil, which is a big country, as you know, and its name was Amil, was and is. It's a big net of hospitals and an insurance company and providing healthcare all over the Latin America. And that company later on was bought by UGH, United Health Group, who UHG, that's it, sorry. That is an American company, and the second one about the volume of marketing they are providing all over the world. They are present in America, of course, in all the American Latin through Amil. They have another sub-company that's name is Optum and is operating in Europe and also in India, for instance. And of course, they are also in Europe, in Portugal and Germany, I suppose. What else? The values of this group, it's an American company. It has a very, very strong compliance set of rules we need to follow and setup of operation. And the values are integrity, compassion, relationships, innovation, and performance. So this is what we are. This is our presentation. And again, I want to welcome you. It's very, very kind to be here with you. I hope you can participate. Please don't be shy, and let's have a completely open talk about our topic today. I would like to thank also to Johnson& and Johnson by the very kind support of this activity, and of course also to Livia and MCM company because of the technical support, which has been also great. So after that, I would go for the case presentation for today. Let me just open here the file. I'm going to share my screen now. Não, vou passar para o caso clínico que está, eu já o abri.
É PowerPoint?
É PowerPoint.
É este, é este.
É este?
Sim.
Não, não é este, é outro. Agora tenho sempre um problema que é não conseguir mexer nos comandos do PowerPoint para mudar para o outro. Como é que eu vou?
Ok. Então,
Eu devo ter dois abertos.
Não.
Não. Aqui não. Ou fecho este e volto a abrir.
Sim. Deixa eu fechar a compartilha. Deixa eu compartilha. Pode compartilhar o iPad do computador.
Faz mal. Abre aqui. Eu estou a abrir o errado. Just a moment, please. Sorry. Eu estou a abrir o errado.
Welcome.
Não, só um bocadinho.
Apresentação caso clínico.
É isso mesmo. Aqui. Agora compartilhemos. E agora vamos pôr neste modo. Okay, so let me tell you something about the patient that is now in our OR. It's a conversion from a sleeve to OAGB. This is a patient that in 2018, a woman, 69 years old at that time, and she was 82 kilos, 150 meters, and the BMI of 36.4. She has a old running diabetes, type 2 diabetes, not so strong under oral hypoglycemians. She had an hypercholesterolemia, osteoarthritis, and a slight reflux, a GERD. She was taking medicine like simvastatin, sitagliptin, plus metformin. non-steroid anti-inflammatory drugs, and bromazepam. And she was characterized as a volume eater at that time. Because of those characteristics and mostly because of the not so important BMI, she was indicated and submitted to a sleeve, which was uneventful. The weight loss was good, 76.6 kilos after 1 month, 69.8 after 3 months, and 1 year after she was 59.2. The diabetes was okay at that time without medicines, so it was successful with the H1C 6.3% and no medication. The cholesterol went down also, but she was with some reflux yet at that time. We performed an endoscopy that showed the gastritis with foveal hyperplasia in the pathology, and the body swollen showed some gastroesophageal reflex in the provocative test, but without any kind of hernia, hiatal hernia. In February 2021, she came up to us with the complaints of reflux and asking for a revision. She is now 66 kilos with a BMI 29, so weight is not so important. Anyway, she would like to decrease a little bit the weight because she's very, very small. The type 2 diabetes is still good with the H1C 6.1% and with an hypercholesterolemia. She's still with the reflux, the most important complaint, and the labs show that cholesterol is 228 with LDL 130, good albumin, and a negative PCR. We perform a barium swallow now this year, and you can see here the image with very acceptable sleeve shape, but with some dilation of the GA junction. Here again, here we can see some hernia, it seems so. And I suppose this is the video. You can see here the dynamic image with the dilated cardia and some transitional hernia at least. We performed also an endoscopy that showed nothing more than one gastritis in the antrum that we could see here with some pyloric fundic mucosa, not so important. And because of that, we proposed a revision. She has also a polyp with 12 millimeters in the gallbladder, and we are going to perform the cholecystectomy, the hiatal hernia repair, and the conversion to OHGP, MGP. This is the case. Now, I would like that we have presented ourselves and we have presented our case. I would like to know your opinion and ask you to present each one of you, telling us where you will do work, what you are doing more, your main sim operation, and what about your experience with revisional OHGB. Okay? Can I begin with Massimiliano de Palma?
Hi, Rui. You hear
Hi,
me?
Massimiliano. Yes, I can.
I'm really enjoyed to be here. Thank you. Thank you for the meeting. I really enjoyed your presentation, and I think I would like to say to you that I usually do this kind of revisional procedure. I would like to look how do you do it, but I'm sure that you will make us very easy what we have to do in this case. I think is after our meeting, I start doing more and more OIGB. And so I think it's very useful that what we have said in our meeting before, and I would like to meet you again to understand any tricks and tricks to do it again.
Let's try to do that. Thank you. So, Dr. Dimitris Lapatsanis, I don't know if I am spelling together correctly.
Yeah, that's right. Good morning from me too. I really enjoyed your presentation. Since if I understood well, the main problem of your patient is the GERD problem.
Yeah.
Why didn't you consider of performing a typical Roux-en-Y gastric bypass.
Sure. But can I ask you, where do you work? In Greece,
In
I
Athens.
suppose?
In Athens.
In Athens, okay. So that was the question
I
I
do.
was waiting.
I am fond of OAGB. I perform some, but you know, since it's still some conversation going on about the reflux after OAGB, and as you said, the main problem of your patient is the reflux. Why didn't you
Yep.
consider a typical Roux-en-Y? Thank you.
Good question. Good question, and I was waiting for it. Look, indeed, in some algorithms, Roux-en-Y gastric bypass is the more appropriate solution for this kind of situation because weight is not so important. The weight loss is not so important. You are right. In our practice, and being completely transparent and honest, in those kind of situations, we perform more what we call before the diverted OAGB. I don't know if you have heard about that, or the long pouch gastric bypass, a technique that we began in 2013 and has outstanding outcomes in this kind of situation. So that would be our first indication. Why did I propose the OAGB? Because we are in a course,
Okay,
and I had to find a case for this demonstration, and it was the possible case at this time because we have from time to time, not a lot of cases of failed sleeves here. So anyway, if you agree and if we are going to make an agreement, in the end we can demonstrate the OAGB conversion. That in some opinions it would be enough because it reduces the pouch pressure and the differential of pressure between esophagus and the gastric pouch. So in many opinions it can solve the reflux issue, but indeed I prefer to be more to make the patient in a narrow safety range and to give him the power of OAGB with the diversion, treating the both situations. Okay.
Okay, thank you. Let's enjoy then the conversion.
Okay, so let's ask other colleagues, our friends. Francesco Greco, are you there?
Ciao Rui, sorry,
Ciao.
sorry for the delay. How are you?
Fine, as you can see.
Okay, have you already finished the surgery? Not yet.
Not yet, not so fast.
Okay.
It's too early. It's 8 in the morning, so 8:30 now. So tell me, what do you think about? Can you present yourself to the other ones that cannot maybe know you?
Thank you, Rui. I'm Francesco Grego. I am bariatric surgeon from Italy. I work in Brescia. I was born in Rome. And I am a good friend of Rui Ribeiro. I have had the honor to visit and to operate in his clinic, with his wonderful team. And what about today? I have studied the case, Rui. It is very, very interesting. I have a question for you, first of all.
Sure.
Why you are not for a diverted NGB in these cases?
I said it before because look, the goal of this course is to show an OAGB conversion. Okay, I told you that my first option would be and is usually the diverted OAGB. And in this case, if you can agree after the OAGB conversion, our task is completed and we can go for that step, for a further step, if you agree about that. I suppose it's more safe. Although OAGB is not bad and it could solve the problem with the hiatal hernia treatment and the decrease of the pouch. In the end, it could also work, but it will be more probably. Because we know we are going to discuss that later on about the literature that is available, that the rate of reflux after this kind of conversions it exists, so it's not negligible, and we can avoid that with a supplementary step. So let's discuss that. Well, Fuzia Mesheri, how are you? You have been with us. Ciao. Are you okay? Can you present yourself to the other people?
Hello, I am
Hi.
Zia Missouri from Italy, and it's a pleasure to see you and to hear you.
Same.
And I hope to see you next soon.
In Naples. In Naples.
Present. Yes, yes, yes.
Good.
See you.
Okay. Any comment about the clinical case? What would you do in this situation? What would be your preference? Would you go for an OAGB in this patient or for a Roux-en-Y gastric bypass or a diverted OAGB?
I'm sorry, but I just collect, and I don't.
Okay. Okay, you didn't
don't
see the
the case.
presentation. Okay, we'll
Yes.
come back to that later. Marco Fatiga, good to have you here. Big compliment to you also.
Thank you so much, Rui. I don't know if you can hear me. Sorry, just
Yes, I'm listening to you. Good to have you here also.
yes, it's a real pleasure and good morning, everyone, again. And so I hope you will join this wonderful session and hope you to meet you everyone in person at the beginning of next year in Naples. So thank you again.
Thank you by your support also. And
Thank you so
you are
much.
one of the founders of this masterclass, so congratulations for you also.
Thank you so much, Rui.
Oh, let's go to the next one, Dr. Luca Cesar. Are you there? It seems he's not. Dr. Arturo Merula, are you there?
Yes, I'm here. Good morning,
Hi.
everyone.
Good morning.
Thank you.
Can you open your camera, please?
What?
If you can open your camera in order to
Okay,
see
sorry,
each other. Sorry. We have here, Dr. Arturo. Okay, good to see you.
Thank you.
That's because some of the participants have been here in another session, but the other half we haven't been here. So I would like to know your image. Thank you.
Thank you so much for your kind invitation. And just a few words, I live and work in Naples in a public hospital called Fate Bene Fratelli. It's a religious property, but it's in all kind of its services, a public hospital.
Right.
Yeah, I'm just here to waiting to see the procedure and to appreciate some technical details by your procedure. Thank you so much.
Sure, thank you. Meanwhile, my assistants are beginning the operation. They are going to the gallbladder, to the cholecystectomy, but I suppose that's not so important. We can talk a little bit more. So, Dr. Silvana, good to have you here also. Hi, can you present yourself? You are not listening. I'm not listening to you.
Silvana, you have to open your microphone.
That's it.
Sorry, can you hear me now?
Yes, it's okay now. Thank you.
Good, thank you. Good morning, everyone. I'm Silvana Leanza, and I'm working in Iesi, Ancona, in Italy. Yes, and I have seen the case of today, and it's okay for me. It's the first choice to
Good.
OAGB.
OAGB would be your first choice, right?
Yes, in after sleep, yes, it's the first choice. Thanks.
Do you have experience with conversion from sleeve to OAGB? Did you perform cases usually of conversion from sleeve to OAGB? Do you do it usually?
Yes, I have done some cases, just some cases. It's a little center myself. Yes.
So thank you so much. Thank you. Dr. Pier Paolo Cutolo, we have been here with us, I suppose.
Yes, do you remember just Just
Sure,
a few
sure.
days before the pandemic spread through the world. I remember when I came back from Lisbon, I heard that the first case in Italy was arriving. So that was a mess. And
I remember you commenting on the devices on the lift wall about COVID already at that time.
Yeah, really. So it's a great pleasure to see you again. We already have discussed about these cases, and in our clinical practice, we perform usually Roux-en-Y gastric bypass when we see that kind of reflux, or maybe we convert from OAGB to a diverted Roux-en-Y when in a second moment we see a bile reflux.
Yeah, you can do as a second step, of course. But that's what we're going to discuss. We can do it as a first, as a step in the first operation, keeping the safety for the patient. That is usually and I have, I suppose, 34 cases of conversion from sleeve to diverted OAGB, and the outcomes are really good, even for weight loss. If we keep the rules of the OAGB with a longer biliopancreatic link, in a revisional case, we need to do so. The weight loss is also good in patients with the weight regain, even an important weight regain, and keeping reflex far away. Okay, thank you so much. The next one will be maybe Dr. Michele Giuseppe. Are you there?
Good morning.
Good morning.
Good morning to everybody.
Welcome.
Thank you for this meeting. I am Giuseppe Iovino from Naples. I work in Cardarelli Hospital. It's the most important hospital of the city, and I work in bariatric surgery from 4 years. And so I'm here for see this case, and thank you for this opportunity.
It's my pleasure. Thank you so much. What else is here? Who else? Doctor. Oh, I can't understand that Greek name. I'm sorry. You doctor with a white vest and a blue tie. I suppose you're from Greece. Here. No. So, Dr. Georgios Iomamitis. Is that the right way to spell your name? Are you there? No.
They are Greek delegate online.
They are delegate. Okay. Okay, so let me just a moment to check how is the things going into the OR. Just 15 seconds, please. Okay, they are already operating, putting the trocars, introducing the trocars, and I would like to make some kinds of considerations and have a short discussion with you with something that can be funny. Let me try to get my presentation. Oh. I need to... Como é que eu descompartilho? O rato desaparece muito. Fechar a tela. Ok. Sim. E agora fechar esta aqui e abrir a outra, que é esta aqui. É, não é? Também dá? Okay. So I would like to just to make some considerations, some comments about this kind of situation we are facing today. And I would like to begin. I presented already myself, and my task today is to promote a discussion between us and to make clear how we can deal with this kind of situations. And I will begin with this image. It's a kind of a joke, and let's see what is it. So, somehow funny. Are you listening to me? Se calhar não tenho.
Yes, Rui.
Okay. So, my question to you would be, is this a failure? And I suppose yes. The people that couldn't get the proper goal that was to have a camel ride, a short one. And thinking about this, why didn't they get the success in this task? We should think things like people didn't know the risk they were running for that trial of getting on a camel. The camel driver didn't thought it could happen. He probably was not experienced enough, and he didn't prepare the ride properly. And he didn't have a rule, because we know that in safety systems we have rules, and we have, for instance, weight capacities limit. So those two people were too heavy for that camel, and they didn't know that. They didn't measure the risk, and didn't add even the scale to measure people. And he didn't know very well how to solve the problem. He was completely improvising a solution. And there was no emergency support systems. Imagine that if that man or woman would break the neck, how would be? Where was the emergency transportation for the hospital? It was not there. And finally, they couldn't get the goal, so it was really a failure. In bariatric and metabolic failure surgery, we have also failures, but we define it completely different. We define it when people don't get the desired weight loss and insufficient weight loss, when they regain weight after the operation, and when they don't have success about resolution of associated diseases. So in those cases, we consider the procedure is failing. And of course, it's more common in restrictive surgery like band or sleeve, although sleeve is a mainly restrictive surgery with some metabolic effects. And in this kind of situation, OAGB can be a good salvage technique. We know that sleeve is a good technique, very popular nowadays with a lot of advantages. It can be acceptable, in my opinion, as a first step for many operations, and we have an exit door for any kind of failure or complication. But there is an associated failure rate, very high in my opinion. That's why I don't perform so many sleeve gastrectomies. And considering that obesity is not a curable disease, it's a chronic evolutive disease, and we need to have different treatments in different steps of the different stages of the disease, it's okay to do a sleeve as a first step. Anyway, I prefer to go further. We know also, this is an independent study from Paul O'Brien and his team that studied the reoperation rates with different operations in Australia, and looked that sleeve is the one with the greater rate of reoperation because of probably GERD and weight regain. You know, the work of Alfredo Janko showed the high rate of reflux and Barrett's esophagus in after sleep. And this is a really new study from this year from Ralph Petterly in Switzerland that found de novo reflux in 32 cases of sleeve after sleeve, and he had to reoperate 1/5 of his group that were, I suppose, almost 100 cases. And another recent work from the Fathom Reich and the Vera Prager group that has promoted and showed that before, at 10 years, also an increased rate of Barrett's esophagus after sleep is coming with 15 years of follow-up in 53 patients, and half of them were converted to Roux-en-Y because of weight regain or reflux. So Roux-en-Y is, in his opinion, the best option. Of course, that the treatment of failure is not only surgical. We can combine both approaches, medical and surgical, but we should try, first of all, the medical treatment. Let's see. And mainly because there is not a direct correlation between the symptoms and the anatomic abnormalities in the esophagus, because we have cases with a very important reflux without any kind of esophagitis, and the opposite also. We need to study the patients, first of all. Other issue is what are the cases that can fail more with the sleeve. We know that the non-compliant patients, sweet eating, grazing eaters, the patients that are not compliant with any kind of rules, and our psychologist is telling us that he's not compliant, so should we perform a sleeve? Maybe not. We know that also in super obese people, it's not very effective. It's insufficient for most of the patients. We know also that there is a correlation, and it is more a technical detail, between the size of the bougie, the caliber of the bougie, and we know that the bougies with bigger than 40 French will induce a smaller weight loss in the future. And of course, technical mistakes can happen because of difficulties or insufficiencies, like the camel driver, and we can leave retained fundus, dilated antrum, total gastric dilation. We can see some images later on, but that's not a this is something human. There is a learning curve, and surgeons in the beginning of their experiences, they are more prone to commit some kinds of technical insufficiencies. Another issue we need to understand also is the importance of the dropout, because for sure, many cases will fail because they are not being followed up. And this can be his fault of the patient because he's not coming, he doesn't want to come, he doesn't want to take pills or vitamins, he doesn't want to spend money in more appointments and coming more time to the hospital or to the office, but can also be a fault of the team, because we know that some teams are not providing the adequate level of care for the patients. And we know that patients that are being followed up with the multidisciplinary team have better outcomes than the ones that are not doing so. Going forward very quickly for some studies, Rodolf Weiner studied a group of 106 patients that have initially a gastrectomy, and they were converted because of insufficient weight loss or GERD. And he found 50% of the patients had some problems, anatomic problems in the study. Of course, some patients can be perfectly operated, and they will develop those anatomic, for instance, dilations of the fundus or of the antrum. Those are examples of situations that can promote the weight regain easily, or even the reflex. Those are, sorry about the formattation, it is not good because it comes from Macintosh to from Keynote, from PowerPoint. Those are all cases of our experience, of our patients, and we have found different kinds of complications like the dilation, the global dilation of the sleeve, the dilated antrum, with the weight regain, or retained fundus with the weight regain and reflex. And in our experience, the two situations in most of the patients, they were associated. The patient was regaining weight and having reflex at the same time. The stenosis is an important cause of reflux because of the high pressure above the stenosis and the hiatal hernia, as you can see in the image in the right of the screen. We should perform some kind of imagology studies, like the camel driver should evaluate better the patient, the client he had. We need to make a barium swallow. It's a cheap and easy examination. And the CT with 3D reconstruction is probably the best option if you can do that, because we can see the shape of the stomach, and in this case, we can see the torsion of the staple line, indicating that there is a torsion of the stomach. Of course, endoscopy is also mandatory in this kind of patient to evaluate the GA junction, any kind of important gastritis, the hiatal hernias, the Barrett's, and whatever we can find that will be important to our decision in the operation. And how should we manage the failure? Of course, doing the evaluation of the patient with the history and physical examination, and the IGI study and endoscopy. Behavioral intervention, it's important. We can save some people from operation with a behavioral intervention before with the multidisciplinary team, and we can benefit patients with that approach. And finally, what can we do for those patients? There are different solutions in the market, I would say. Some people are defending yet or still re-sleeve. People that are performing a lot of sleeve, they defend it yet. Some people are performing the sleeve with a band. The plication of the sleeve is also performed by some people in order to reduce the dilations. The Roux-en-Y gastric bypass is a good solution, mainly when there is reflux, of course, and the duodenal switch and the SADS are probably the best techniques for to solve a weight regain. But we know that because of the high rate of complications in the long run evaluation, nutritional complications mainly, it's not so popular, and also because it's technically more demanding than other techniques. And they can be performed in 1 or 2% of the cases, maybe. OHB is a good option because it's more simple and somehow malabsorptive, but not so much, and the outcomes are good. And finally, I would consider also the SAZI or the bipartition, transit bipartition, that are good techniques that can help also in this kind of situation. About how should we choose the kind of technique, of course, evaluating the volumetry is important. The group of Michel Gagne, they consider it very important, and it's an important criteria to choose the technique. Jack Impens is more prone to give importance to the presence of reflux or weight regain, and for reflux is going to gastric bypass, and for weight the opposite. For reflux is going to gastric bypass, and for weight regain for malabsorptive, including OHB. This is the same criteria. It's also important the kind of nutritional profile of the patient, the eating pattern, hyperphagic people that eat large meals, they repeat the injection, and so they will do better with the restrictive surgery. And the polyphagic, that people that are always taking small meals, they will work better with disabsorptive surgeries. And I would finish here. Perfect, because they are calling me to the operation. So I will leave you for a while, and I'll come back since the operation. Okay? Is it okay?
Thank you, Rui.
Thank you. So see you.
Excellent presentation.
This is just one entertainment before the operation. Okay, thank you. Hey, dear friends, are you listening to me now?
Yes.
Yes.
Yes? Okay. So, first of all, temos imagem de fora? Okay. First of all, I would like to present our team. So we have in the surgery Dr. Otávio Viveiros, that will be with us later on. Dr. Carlos Trindade. Our nurse is our joyfully André Ferreira. And Dr. Emmanuel Silva is our anesthesiologist. Hi, Emmanuel. He's very modern. E.Manuel. So electronic manual. We have also Dr. Vasco Geraldes that is here, and he's going to receive your questions and transmit them to me during the transmission. I will try to answer later on. So they have already performed the cholecystectomy. We have the patient in lithotomy position as usual. We are going to use the 3D image. As you can see, the ports are done as we do it usually, even for primary surgery, with one 12 trocar over the umbilicus here, another 12 here, one 15 because the optical doesn't fit in a 12. We need a 15 for the 3D, 1 5 there, and the net and liver retractor there. So they have already performed the cholecystectomy. Give me an instrument. Podemos apagar a luz agora, por favor? Segura lá a câmera, por favor. Carlos. Let me check what they have done. Okay. Good work, guys. That is the ileum, the cystic duct. Okay. We have some clips here. Let's begin with this. This is one of the risks of this kind of operation when we use a lot of clips when we are making the firing the staplers, we can get a misfiring because of those small pieces that are in front of the blade, as you know. So I won't cut here, but just to show, we can remove them before, and we must be with attention to that in order not to get that complication. You can remove it easily. So we have here the sleeve. We have some narrowing here, not very important, but anyway. We have already the bougie inside. Pode mexer o tubinho, enfiá-lo para trás e para a frente. Okay, you see the bougie already here. Um bocadinho para trás, Emmanuel. Está bom aí. And let's go to the upper part of the sleeve. We have another. No, this is not a clip. This is a staple from the. Okay. We have a stitch here. It means that I gave a few stitches. I put a few stitches before. So, and let's go. So the first step will be the dissection of the nail greater curvature. I'm going to use the end seal from Johnson & Johnson. It's important in this step to consider that we should not approach too much the stomach, the gastric wall, avoiding to burn it. Um bocadinho mais perto. We have not so many adhesions from the first surgery. Enter. As I told you, please keep an eye in the staples that we can have in front of the blade. Agarra-me aqui, desculpa. Um momentito. Puxa, vai puxando. Não me deixa para baixo. No staples. Another issue, and Octavio is going to talk about that later on, is try to avoid to damage the vessels. We don't want this vascularized tissues around. Aqui primeiro. We have a certain amount of fat that is not so usual here. Mais perto aqui, por favor. Levanta lá aqui, que é para cortar aqui. Como é que é isto? Espera aí. Um bocadinho. Afasta-me aqui. Agora. Agora aqui outra vez. Gordura, não é? Gordura. Temos aqui uma coisa. Aqui, temos que ir aqui. E uma adereça que nos dá um gancho, por favor. Maybe it seems to have here some dilation of the fundus. Alguma pergunta, Vasco, por aí? Mas podes convidá-los a fazer perguntas. If you have questions, please proceed.
Rui,
Sim?
can you hear me? It's Francesco here.
Sim? Francesco Greco.
Ciao. In this case, I think that the mild stenosis near the antrum can promote reflux more than.
You can have it, yes. I told you there is somehow narrowed that area, and that maybe that's in connection with the reflux that the patient complains. Sure.
So what is your
Theoretically,
choice in this case?
it could be enough to fix that stenosis.
Okay, but your strategy
OHGB with an anastomosis above that. Ajuda-me aqui bocadinho.
Where you will put the anastomosis?
The hiatus, and later on we'll face that problem. Outra vez, esta gordura toda da frente, agora já percebemos melhor o estômago. André, hoje não pode dar fios curtos, está bem? E eles dizem que eu tenho a mania dos fios curtos. 2 centímetros mais.
Rui.
Sim.
In standard OHGB, do you usually fix the hernia or not?
Se ela for maior que 2 centímetros, sim. Ou se o doente tiver queixas importantes previamente. Aqui agora? Sim. Tem mesmo aqui uma introduçãozinha, estão a ver? So in this step, my goal is always to find my landmark, in this case the left crust, because I want to evaluate the size of the fundus, and we are probably discuss if we should trim it or not. Aqui, entra ali onde eu estou. Vira aqui para cima. Isso. Deixa de estar, deixa de estar. Deixa-me para tirar aqui esta câmera da frente. As you can see, N-Seal is very effective. Maybe not so fast as the ultracision that you use usually, but in visual cases, I prefer because I can do something like this to use it like a bipolar without closing the device. Otávio, any comments? Não tem microfone. Ah, sim, mas fala aqui perto.
Okay. I think that's what Dr. Rui said. It's always important to have your landmarks and just to navigate with your line of shore at sight. So don't go on strange waters. Always keep your landmarks, and you will be fine.
another comment I would say, is some people that say that you see there some clips. Pay attention to that. We have there some clips. I was saying that people say that sleeve is an easy operation to fix and convert to other operations. Not so easy sometimes difficult, and it's not a job for less experienced surgeons. So if you don't feel comfortable with that situation, you should ask someone to be with you. At least in the psychological point of view, it will be helpful. Now, I need to what I've told you about vessels and not to damage vessels that are nutritional for the gastric wall, avoiding any kind of ischemia. Something that is very useful in this kind of surgery, and we have it available, is the... Dá uma compressa, por favor. Vamos ter aqueles clipes dali. Só um bocadinho. Is the ICG technique, and with ICG we can... Como é que ele está? Ao contrário, não está? Vá para lá. With ICG we can evaluate the tissue vitality when it is in doubt. If I will have time, I will show you some clips about that today. A compressa agora, por favor. Faça assim em bloco, por favor. I do like to use gauzes because they can retract easily the excessive fat. So we are approaching our left pillar. Another clip there. It's not my habit to put a lot of clips, but tem que chegar mais perto para virar o estômago.
Esse pode estar no estômago.
Pode
ser daqueles.
Ok, let it be. Não ficar uma coisa assim grande aqui, não vai escorrer. Ok, deixa estar um bocadinho. Ok, I'm going to make a break in this side. So let's dissect a little bit lower. Oi, Manuel, depois prepara, por favor, um sorinho para meter pelo tubo daqui a bocado, para vermos aqui se tem estenose ou não. Troca. ver aqui, levanta aqui um bocadinho assim. Está bem. So now we are going to perform mais um cortezinho. A simple test. I'm going to ask our friend anesthesiologist to inject serum by the bougie, and let's see how the stomach feels. And in that way we can check. Está muito comprido este fio, encurto lá um bocadinho este fio branco. Babcock. If there is any kind of torsion, stenosis and or torsion. Sometimes you don't have a stenosis. The stenosis is functional. I mean, it only torsions when it fills. So, agora, Emanuel, por favor. We are filling the stomach. You see, there is a kind of functional torsion here. We have two compartments, one here. Anyway, there is a good way out. There is a good way out through this kind of. So I would say that the torsion and the stenosis is not so important. Francesco, do you agree with me?
I don't know, Rui. I don't know, because hopefully this stenosis distortion is very far from the AG junction. So I think you can put the anastomosis at the level of the stenosis itself.
Can you repeat, please?
Vamos agora para o pilar direito. Temos que pôr melhor aqui esta coisa. Assim. Oh, Pedro, mandou os convites para aquela gente. É para aquela pessoa que eu também pedi, não foi? Sim. Obrigado. E agora? So here we have the inferior vena cava. We have the stitches of the previous scleroplasty that it seems it was not sufficient at that time. But we know that tubulizing the stomach will be always a reason for a future migration of the tube into the mediastinum. It's something that happens with sleeve, with OHGB, what kind of, even with SASV, probably bipartition, any kind of sleeve plus technique will have that problem also. André, prepare-me um endostitch com o V-lock não absorvível. Uma coisa que eu me esqueci de pedir, é verdade. Dá-me um dissetor agora. No service. Por baixo. Okay. Yes. Service. Okay. Lugar em cima. Já, pelos vistos, estão aos pontos. Okay. You are asking if the hiatus has been treated before. Yes, I've done it because I keep I didn't have I didn't saw it in the registries, but those teachers tell me that I have done a pleuroplasty before in the first operation. So we have our right pillar, which is an important landmark. At this step, we need to be careful about the vagus nerve. I want to keep it healthy because of the gastric emptying, of course. Gancho. Gancho. Put the key. Vamos lá. Empty in the sleeve, not here, of course, because they're going to have a wide anastomosis. Vou ter disparados. Ok, tanta coisa. Certa, não é? Essa é uma história em português. I suppose the vagus is here. Be careful of the pleura. I'm far from the pleura also. No problem. Now I need to find the left crest, of course. I suppose it's time to go to the other side. Okay. Toca-me aqui, o dissetor, o gancho. Direto. Okay. Parece-me sempre chato aqui nesta. Hã? Esquece mesmo de sair. Já ficou contra a tração. Tá, mantém-me assim, força. Tira aqui com o gás. O outro era só um clipe, não é? Sim. Gancho. Some scar here. It's dull. Tá fácil, esta figurosa, né? Hã? Eu tenho aqui, eu estou a sentir que estou no plano certo. Mas aqui, cara, está a ver aqui, não é? Não quero queimar o estômago. Here I'm thinking that and saying to Carlos that I don't want to burn the stomach, so it's somehow risky to cut it here. Anyway, dissetor outra vez? Dissector? Não. Não. Vamos lá aqui. Consegue ver aqui a função? Sim. I'm going a little bit further down, trying to find the left breath without scar lower. Again, don't cut vessels, important vessels at least. Here. Don't burn the stomach, so we have too much, don't. But we need to be thinking all the time about those. If you don't want to fall from the camel. You see some hernia here, this is stomach, inside the mediastinum here. This is a vessel. Yes. No, no. No. nossa imagem. Here, the crest, finally, and now I can see it again. And I do prefer the hook because it's more tiny. I burn a little bit here, you see? Or maybe it's scar. I don't know. I'm not sure. Vamos lá mais perto agora? No, this is scar. Não vai, não é? Mas se calhar isso tem que ir à vida. Hã? Por aqui? Mas aqui. Mas aqui não tem túnel. Lá? Pode ser grave. Vamos ter outra máquina. Boa. I need to cut this strip that is an obstacle to get the lower part of the left crest. I was wondering if it was not a vessel, but anyway, if it would be, I need to cut it. We have here another addition because of the stitches, probably. You see there, Zona, scissors. Boa, Carlos. Muito bem. This is a stitch, indeed. Okay. Another stitch. Maybe we don't need to cut anymore. Ok, vamos agora. Carlos, vais-me puxar aqui a união ao fundo, para baixo, para eu secar agora com a compressa, de um lado e para o outro, para ganhar espaço. Going to dissect into the media assignment in order to get some extra esophagus length. You see the other vagus here, okay? I like to do this with the gauze in a blunt way. And now let's look at the below the. Oh, Emmanuel, tira o tubinho um bocadinho para fora, por favor. I'm going to ask Emmanuel to remove the bougie now, because I want. Podes. Throw it off. Mais, tá bom? Because I want to have more space to work. Hã? Não. Puxa aqui esta coisa da frente. Is you see the vagus, the other vagus was here. And the left pillar should be somewhere here. Okay, I'm in the other side. I'm on last. Last. Focus. Levanta-se tudo para cima para ver se encontra o pilar no meio da gordura. Está bom. Eu tenho que cortar esta gordura aqui porque we have too much fat here and I can't see. Otávio. Just a moment. Otávio is not has his glasses blurred. So the crest is there. I can see it now. Vai lá, Otávio, vai lá. Estás? Okay. Ainda temos aqui uma aderência. Estou muito stuck. És tu, Carlos, que me estás a... És tu que me estás a aprender, não? Vou pelo outro lado, agora. Tenho que passar por baixo de ti. Já está, já está. Vamos lá. So we have the pillar here. I'm not seeing very well from the other side. I need to look at it clearly. And I'm not being able to do that now. Let's remove this gauze by now. Essa está direitinho. Gauze off. Passa a palavra. Opa, se eu for à frente, tem que encontrar, né? Se eu for lá mais à frente, aqui. Acham?
Estás muito tenso.
Estou nada, estou nada. Ok? I suppose I don't need to get this. I will just, I need to. No, I need to get yes. Going low. At this moment, think about the thoracic channel. Then então, Ok, chega. Ok, the end of stitch. So I'm going to perform a curioplasty now. We saw that we had a bit of stomach inside the mediastinum, but it is not there anymore. Tirar isto? Octavio is asking me to remove this. What do you think about remove this? Alguma opinião daí? Nobody can help me. Should I take this off or not? Okay.
Everybody saying yes.
Here, everybody say yes, so I'll do it. I'm a Democrat, you know, sometimes. Ok. Sim, não sei, mas mais tarde ponho. Vamos passar o tubo, Emanuel? Podes. Já passaste? Estica um bocadinho. Espera aí. Estica. Entra agora, vá. Vá, já entraste. Deixa passar, Carlos. Ok, tá bom. Obrigado. Vamos continuar a sutura. Não, vou fazer. Não nos vou ensinar essa. Essa fica para nós, está bem? Não tenho certeza se é uma boa atitude, portanto não vou estar a divulgar uma coisa que é incerta. Está subindo ali, não é? Ok, we have some tension, you see? So the pillar is steering.
Dizem que a minha incentivada perguntou se faz prótese.
Not big enough for that. The hernia is big, but only I used to put a lot of meshes, but in hiatus, but only with the big hernias greater than 6 centimeters at least. Okay, I suppose the hole is reduced. Good. Pela esquerda, claro. Vamos lá. Agora para baixo, Carlos. What we used to do now, afinal vou fazer, is to put a couple of stitches here. You see, taking a bit of esophagus without nerves. And trying to fix it to the diaphragm, to the vamos, por favor, isso. That's enough. Usually put not one stitch like here, but 4 stitches in running feature. But I suppose it's enough. What do you think about this kind of repair? Vasco, tell me. Podes tirar. Compressa, está lá alguma? Está uma, não está? Vamos lá tirar a compressa. Não, afasta que eu puxo. Mete mais. Não, não é preciso. Sim. Muitas vezes aqui à frente, como fizemos. Sorry. Sorry. My brain was a little bit confused now and speaking Portuguese. Usually we make a kind of a cruroplasty like that one, and we put some stitches now. This is our more modern way to do it here, like a short running suture from here to there. I learned it from Catalin Copescu from Romania that is doing that like that. But before we are performing esophagopexy or gastropexy, taking stitches from the GA junction to the lower part of the pillar, to the, cuidado, como é que se chama? Ligamento arcuatum area. And there is another way to do it, defended by Sérgio Santoro in Brazil. That would be to keep a part of the fundus like this and stitch it to the diaphragm here in order to make a small valve, a little bit like the ESOFIX device, if you know the concept. But I will leave it like that. Another discussion, should we remove this excessive fundus or not? What do you think? Francesco? We have 2 options, 3 options. Leave it like that to make a plication or to trim it. No answers. Okay. Please feel free.
Do you think that there's enough space
I think
for
I'm going to trim it with the black cartridge, please.
Yes, you should re-sleeve the pouch.
Right.
You do.
I'm going to re-sleeve to trim the fundus, at least the fundus. Okay, puxa-me aqui um bocadinho. We can consider to trim all the pouch because it's always good for the weight loss, but the patient is not has not a weight problem, as I told you before. The issue of the patient is reflux, but this kind of large fundus with the excessive acid production can also make work in favor of reflux. So that's why I'm going to trim it. I'm not closing the jaws of the device. You see, it's like a bipolar device. A regular one, not closing it. Deixa estar aí, não preciso mexer aí. Deixa, solta. Compressa outra vez, limpinha. Já tem a carga negra. We are going to talk a little bit about that later, Otávio at least, and me maybe. But in this kind of situations, of course, we need to use staples, iron staples. So, because the tissue is fibrotic, another care we need to take is to try to find the previous staple line that I suppose it's nearby in this line, not avoiding leaving any tissue between 2 staple lines because it can produce ischemia and a leak. So I'm going to clear a little bit those tissues. This is
the herniated part of the stomach before. I'm going to free it. Segura-me aqui. Ok. Vamos lá. Carga. We could also put here some kind of reinforcement, buttressing material, like a seam guard. We could do that, but I suppose in this case it will not be necessary. Of course, black cartridge is the best option, but a green one, cartridge aqui, por favor, would be also okay. And in that case, probably I would use the seam guard. Puxa. Não está a vir. Não deixa-me puxar ele, vá. Eu tenho o controle da contratração. Puxa-me aqui para baixo o estômago. Vamos, mexe-me o bugie, por favor. Não, é igual. Mais. Okay, the bugie is free. What do you think about this kind of trimming? Any criticism? Do you think it's okay? No, I think it's not okay. I need to cut more here. Mostra lá à frente. E depois vou pôr uma outra carga ali no segurança. We used to wait for about 1 minute before this kind of stapling. No comments there?
No comments here.
B. Já posso? Já. I'm firing slowly, according to the orders of Andrea. You can listen to her now. Outra carga destas. E depois prepara-me um V-lock absorvível. Carga negra, outra, e depois o V-lock absorvível. Não quero endocitos, quero normal. Absorvível. Deixa eu ficar esta aqui. Try not to get the gauze. What do you think about this? You think it's okay? I don't want to be too much close to the esophagus because of the sling fibers and the clasps, because they can be still important to avoid reflux. And as we know, even with the Roux-en-Y gastric bypass, with a short pouch, we can have reflux. Even yesterday, I received a patient that I operated with a Roux-en-Y 15 years ago, dealing now with the reflux, acid reflux problem. She has a dilated pouch. It was small in the beginning, it dilated, and she's having reflux. So it happens in 1%, 2%, 3% of the cases in clinical basis. But if you go for the endoscopic view of the situation, as you know, by the work of Mario Morino in Italy, the esophagitis can be much more important. Vou esperar. E agora quero depois o Viloc. Ver se eu consigo tirar isto já. Acho que sim. We have a 15 trocar. I'm going to remove the specimen immediately. Out. Viloc. And after some fight with Professor Henry Buchwald in a meeting some years ago, when we had meetings presidentially in Istanbul, he was advising everybody to, if you have a staple line, defend your patient as much as possible, reinforcing the staple lines in more difficult situations. So that's why I am going to reinforce the staple line with the Viloc feature, absorbable one. Tá, depois um bocadinho lá em cima. Oi, peraí, estou a apanhar aqui. Já vai um bocadinho. Try to avoid the vessels. Sometimes we can take them and get an hematoma, which is not very nice to view. I'm asking Carlos to hold the thread, not because of tension, but not because of, it's not really necessary, but in order to keep the tissue stretched, it's important. There is a vessel. I'm going to go beside it. Oh. Já para enfeitar. Good. Now I'm going to change the strategy and to do it through and through. How do you prefer to do this kind of reinforcement? With the invaginating features or through and through? People told me. Massimiliano, how do you do it? Everybody sleeping?
It's Dimitris from Athens. I do it invaginating, not through and through.
I do a similar to you.
Okay. One advantage of this kind of feature is that we get an extra invagination, the reduction of the size of the pouch. Done. I'm going to leave the gauze there. Depois preparem a cola no fim, tá bem? Já está. Okay, so we have a stomach. We have our like a torsion, pseudo torsion here, but it's we have some exit emptying pouch. So I would say that tem uma régua, mas vamos ter, não vamos? To go for an OHB, I would like to go in this case above this situation here. If I would go for a diverted OHB, I don't need such a longer pouch, and I would go a little bit above. So, any hints for that? What should I go now? What should I do now? Okay, well. Please help me, tell me, each one of you, should I go now decide to go for a regular OHB or for a diverted OHB?
I would prefer a diverted, Pierpaolo Cutolo.
My friend Francesco.
Prefer diverted.
We saying that? Oh. Diverted, ok. Há uma compressa para limpar aqui depois.
Não tens alfajete, pois não?
Diz?
Não tens alfajete.
Não. Any more advices? Quem é que disse diverted?
Duas pessoas já responderam diverted.
E mais um vai chatear.
Poderá ser de Dimitris.
Ok. Carlos, agarra-me um bocadinho mais perto.
E a resposta anterior foi mais
Boa. Sometimes there are some adhesions here to the pancreas, and we need to be careful about that. That's why I'm going to go so slowly. Okay, we have got our retrogastric space. Ops, sangrou? Não sangrou? Cima ou baixo? So, I will go later on for a diverted, so I'm going to a little bit upper with the dissection. Carlos, não puxa tanto para baixo, puxa mais para cá agora. Na horizontal, está a puxar para baixo. Não, não, para baixo. Lateral, puxa para ti. Isso. Para me dar um ângulo maior.
In this case, it could be more easy to approach from the bottom side of the retrogastric space.
Sure. If I would be in trouble, solta, Carlos. We can always come up from here, put the machine and go into our desired site. Anyway, I felt that it could be feasible to go and it will be more clean to do it like that now. Ora, which color of cartridge would we use here for the stomach? People, tell me. Help me again. Huh? Não percebi. Sim, sim, claro.
Resposta mais semelhante foi green.
Green, okay. Any other hint? Okay. Green. I do agree with you.
A resposta de Paulo o Tolo.
Sim.
Usually use a gold card.
A gold, it would be nice also, but you can see that this gastric wall is somehow thick, you see? It's not so thin, so I'm more comfortable with the green. I was hesitating between green and black, but anyway, green is okay. Carlos, puxa lá em cima. Tentar vir o buraco por baixo. Aqui mais perto. Oh, Emanuel, puxa o tamanho um bocadinho para fora. Puxas. I'm not finding the hole now, but it should be nearby, maybe there. Anyway, I'm going to find it later on. Agora puxa para cá, por aqui, na grande curvatura. Oh, there you are. Mostra-me toda a carga, por favor. Mostra lá à frente, o bico. Deve ser ali, mas pronto. Tá bom. Diz? Agora esquece. Otávio is saying that he thinks that this gastric wall is ischemic. What do you think about that? Is it ischemic really? Huh? So I'm going to have this kind of pouch. So is this ischemic tissue or not? No, I suppose it's, yes, I do agree. I suppose it's only vasoconstriction. But anyway, I'm going a little bit up. Now I'm going to wait another minute. Só que faz. É? Ok.
Quem fez a sugestão da Gold Credits rendeu-se à venda.
Ah, é? Ok. I asked Emmanuel to remove the bougie. The bougie is not here. It's always good to think about that also, because of the camel height. Vocês não percebem, como mostrei no início da apresentação ali, um casal de obesos que ia dar um passeio de camelo, subiram para o cabelo não se conseguiu levantar. E então começou a fugir e eles assim para a frente, parecia o Titanic, e finalmente o coisa dos camelos, o dono dos camelos lá conseguiu recuperar, mas ele não estava preparado. Eu vou ouvir. So you see, we have a nice staple line with a nice staple closure. Let me see if I need to put something more here. Segura-me aqui neste vaso. Isso. Dá uma outra carga. Azul mesmo. I suppose I could cut that part of the staple line, this staple, but anyway, in order to avoid any kind of mistake. And I need to say that the one that said it would be easier to come from here, it is easier, and in the end, I didn't take profit of the whole. I made before, but it could be helpful if the decision would be to go for an OHGB and try to get the longer pouch we could, but this is not the case. Dá-me gancho. You see the back wall of the stomach recovering the right color? Agarra-me aqui, vai, naquela borda do que eu estou a tratar. Isso. Ok. Tá bom. I'm going to clean a little bit the end fill because it's not, it's dirty. Okay. So we have a pouch here. A régua, vamos lá a régua. Emanuel, queres empurrar aí o tubinho para fora agora? Que é isso? Para dentro, desculpa. So let's play a bit. How long is the pouch today? Any hint from you? 16. Ah, malandro que deu isto ao contrário. Vamos lá para baixo. Estica, estica, Emanuel. So I would say that we have a 16 centimeters pouch under stretching. Okay? So wins. Dr. Carlos wins. So now we are going to measure the bowel. We decided some years ago to measure the bowel all the time. Babcock. Haha. Okay, Maximiliano, you pay the bills later on. So we do have the right angle here. I'm going to measure the bowel, and we look that we are not moving the patient. The patient is still in anti-Trendelenburg position. This is 10. I have a graduated instrument, so I can sometimes to measure and to confirm, to check the right measurement. 10, 20, quem conta tu? Conta em inglês. 30. If I want to do it, I can do it like that. It's short. Dá mais espaço, por favor. E tu respondes, dá mais espaço a mim. 16, 70, 80, 100, 110, 120. Segura aqui com a tua pinça. Não, vai para ali direto, vai para e vai pela tua porta, segurar aqui. So I asked Carlos to hold the bowel at 120. That is the, I imagine that 120 of biliopancreatic limb would be enough for this lady. Remember that she is 72 years old, and in those ages, the bowel adaptation is not so strong. So we need to defend her from malnutrition 120, and should be enough for a. Agora, portanto, vamos contar de novo. 20.
30, 40, 80, 90, 100, 110, 60, 70, 80,
2 meters now. 210.
10, 20, 30, 40, 70, 80, 90,
3 meters since the last instrument.
210, 220, 60, 70,
4 meters. 450.
60, 470, 480, 490,
5 meters here, plus 120, of course. 5.
510, 520, 530, 540, 560.
Não pode ir para aí.
570, 580, 590, 6, 610, 620, 630.
630 here, up, ali, 630 here, and we have the ileocecal valve. So 640 plus 120, 7.4 meters. That's the advantage of measuring the bowel. So in this case, with such a longer, the average length in Portugal is 6.5 meters. So, I'm going to 150 instead of 120. Do you agree with me? Different opinions? 150. And of course, we are going to have one more alimentary limbs of 1 meter. So in the end, we are going to have 2.5 meters of exclusive bowel. So she will have yet 5 meters, 4.9. Okay? Não, azul.
Cioè, vedendo gli occhiali.
This is 150. Não leves tanto para lá, por favor. Agarra-me aqui em cima, não agarro em bruto. Yeah. Including the alimentary bowel, Francesco. Not alimentary limb only. Oh, Emanuel, tira lá o tubinho para fora um pouco. Obrigado. Okay. I'm going to put the hole in the middle of the anterior face because I don't want to have any kind of tissue between two very close staple lines. The first staple lines should be around. You see the staple there? Aproxima lá, Otávio. The staple is there, so the staple line is here. I'm going to put it in the middle of the anterior face. Empurra ligeiramente, Emanuel, por favor. Tá bom?
Jéssica diz 2,5 de bílio pancreático de Beatriz.
No. I know you are very, very used to those lengths, but she's 72 years old. I don't, empurra mais, Emanuel. I don't want to put her in risk of malnutrition and she doesn't need to lose more weight. That's why epá, está mesmo mal.
Não sei se eu percebi que é diverted.
Because you are going to perform a diverted. Maybe you are not considering that. Okay, tá bom, Emanuel, mantém-te aí, por favor. Now I'm going to use a blue cartridge. Usually I do it with white, but considering the thicker gastric wall, I change to blue because sometimes with the white cartridge it can be. Mostra-me aquela porta. Bom. Solta. Ah. Manuel, tens de puxar para fora porque se não for assim não vou conseguir. Segura-me e estabiliza-me o estômago. Isso, puxa para cá um bocadinho. É para eu alargar o buraco. Tira o tubinho, tira. Ok. Tá bom? Pode. Usually I perform 3 centimeters large anastomosis like this, but this is a revisional case and I learned from the experience that sometimes those stomachs tend to retract to make a bigger scar and some kind of stenosis. So in this case, I'm going to perform it with 4 centimeters like this. Como? Normal. Now we can check the staple line inside the bowel and stomach. You see, everything is okay. Emmanuel, it's your time to get success. Oh. Stop. Peraí. Ok, entra agora. Of course, tá bom, obrigado. Some of you can tell me that this stomach is a little bit large. Yes, it's true, but remember, weight loss is not the issue. If the patient would be 120 kilos or 130, I would trim this pouch also. Mais perto. Não puseste o adesivo, não é? Eu tenho aqui no bolso direito, se não quiserem tirar aqui o adesivo. Gabriel, está tudo bem? Já aprendeste alguma coisa ou não? Nem por isso. Hã? In the presentation, I've told you that we have 3 bariatric surgeons. Me, Otávio, that has already a big experience with this kind of techniques, and also Carlos Trindade on my right side is the coordinator of another bariatric unit in a city that is 50 kilometers far from Lisbon, Setúbal, where you can eat the best grilled fish in the world. And he works with me since, I don't know how many years, but 10 years? 2 years. 3 years. Não, já estavas cá ainda quando era, já vinhas cá quando era Caliza, não é? Sim. but more regularly since 2018. Pode dar agora ao Otávio, por favor, a câmera. Ao Otávio, se calhar, nem passes para aquele lado, é só porque as distâncias não estão. Olha a outra linha da gráfica ali, filha da mãe. Opa. Garras. In this case, we have that natural epipoplasty that will fall over the future. We need to thank to our Mother Nature. Solta. Deixa-me agarrar bem. I'd like to hold with the needle holder and stretch with the grasp, like this. Vem mais para trás, que é nesta função. Vou passar outro destes. Solta. Agarra. É para fechar. Solta um bocadinho e agarra-te ao outro. Agarra-te ao outro. Vai outro fio, outro fio, outro fio. Vai outro fio. Qual é? Qual é?
Rui, is this the middle holder that Jack Impens has forgotten in Lisbon last time?
Yes, sure. A little bit fat, but very effective. Indeed, that's a story because some years ago, when I was in the public hospital, in the first public hospital, I had this kind of needle holder and I liked it. But after that, I changed to another hospital, the same group, but we didn't have that needle holder. And I forgot a little bit about it. And when we have had here in our 2019 Congress, Antonio Torres and Jacques Impens, they asked for it. And I remember, oh, I forgot it. I need to buy them. Now we have 2 or 3 of those needle holders. Quantos são? 2 ou 3? 2, não é? 2. Well, so this is something that I would like to comment also. I suppose that one of the secrets of OAGB is to get a good axis between the pouch continuing in the afferent limb. If this is in line, reflux is less probable, according to my concept. And later on, I'm going to fix this in order to put bile coming from up to down and not from down to up. So maybe it can reduce the bile reflex or not, but at least avoid the torsion of the anastomosis, which can be also a reason for a bad emptying of the pouch and the reflex. We're going for a blue test. Cap. Emanuel. Sim, ainda estou no modo. Of course, Carlos commented very well that what I'm saying is valid for OAGB, not for diverter. But meanwhile, we are performing at OAGB anyway. Or I would say this is an MGB, and we could finish here, not exactly because I would put the stitches and close the Peterson space. But, recua tudo, Emanuel. Está no capes. Está bom aí? E agora podes. Só um bocadinho, não enchas ainda, que eu tenho que puxar aqui esta. You have the omega there. E podes encher. Ok, tá bom, expira. Não laves. Deixa eu aspirar bem, porque dá-me a tua pinça. Isso. Thank you. Do we know that we have, me and Francesco, we have a common important issue. We are brothers somehow, because we had the same surgical father. Tira. Roberto Taquino. So we can check the posterior stapling line and the suture. Everything seems okay. We can check this corner. Those staples are always bad formally, so it's a weak point that in a time we called it the neo-angular sorrow. 2 gauges above, and I'm going to put a stitch here. Dá-me bocadinho de fio, biquilozinho, uma seda.
Você está a pedir para mostrar a esophagogastric junction, please.
Okay. In a minute. No. Epá, era um bocadinho de fio, André. Foi ao Algarve este fim de semana, né? Ah, mas eu disse para pôr mais, é verdade. Tá bem. Daí. Ok, tesoura. So we want to see the GA junction. Okay, let's go to it. There it is, here. Exactly here. We have the bougie inside. Pode retirar o tubo, Emanuel, faz favor. Put it depois off por agora. You see the curioplasty there? And we have at least 3 centimeters of esophagus here. Stira. I'm going to remove the bougie. Me no, Emmanuel. Okay. Deixa estar aí. You see, Francesco, here. And in the other side, here. And I began my oversuture here. Okay?
Pergunta-se na cirurgia primária.
Yeah, I answered that before. Yes, when they are bigger than 2 centimeters, or if patients have very important complaints of reflux. Now to complete. Thank you. To complete the OAGB, I would put a couple of stitches, as I told you, and I would go, and I'm going to close the Peterson space. Ali. This? Okay, I am going to close it now. Now observable below. Pode ser point of it. Sim. I'm going to close. What material do you use to use? What kind of material do you use to close the spaces, the Peterson and the intermesenteric? Any hints? Sempre. Sempre, always. I don't know in Italian. Olha.
Sempre.
Sempre. Ah, congratulations, people from Italy, because of the excellent victory. I loved it. Oh, Carlos, ontem pegaste-me um susto, pá. O Carlos. Porque olhei para aquela coisa que tu pedeste da festejos dos italianos, eu pensei, este gajo, veste lá, Roberta. Eu pensei, o gajo pôs isto no grupo. Estou lixado. Mas depois percebi que não. Que era só uma coisa particular. Era malzinho. Pois podias. Havia um bocadinho a tua pressão. Now I'm going to pick up the meso here a bit, not too deep. Hey, what happened here? Okay. I'm going to pick up a bit of epiplon like that to keep it in the hole and close the hole. Tem aqui uns bilhos, vai impressão minha. Já passei aqui através disto. Ok. Paciência. Estou ao pé do Bodé e chega. E chega. Hã? Não, não faz mal, vou acabar. Ok, cortas ali, Carlos. Sorry, it was not so perfect because I was enthusiastic with the Italian success.
Então foi Forza Itália.
So, my friends, we can finish here with an OAGB. Deixa-me correr essa. But,
Se usas sempre o vilão.
sim, nowadays, yes. But, as we told before, we could finish here. Please consider the OAGB demonstration, revisional one, done, but the further step will be conversion to diverted OAGB. Carlos. I use usually 1 meter of alimentary limb, and I use the double technique, the double loop technique that I learned from Hans Longroth since the beginning. Ninguém conta? 60.
60.
70.
1 meter.
1 meter. Eu também, mas ninguém estava a falar. So this will be our place for the anastomosis, the enterostomy. Que horas são? É muito tarde, não? Estamos bem. Não, 1h30, 2. A cirurgia pela hora italiana é às 10h30, mas começamos mais tarde também. O meu horário é para acabar às 11. Mas tu, se quiseres agora, podes ir andando para a sala. Vais lá abaixo à portaria do D buscar a chave da sala da qualidade. Mas depois também não temos os técnicos, não vale a pena. Carga branca.
O computador para usar é o Deus.
Depois passar outro V-lock, mas de agulha, não absorvível, para fechar a outra brecha, está bem? Solta. Segura aqui um bocadinho, faz aqui uma preguinha em cima. Ok, está bom, está bom. Solta. Puxa um bocadinho esta para ali. Segura-me aqui agora esta aqui. Pronto, vês? Tá bom, não temos que aproveitar tudo. So use a 60 centimeters solder, Carlos. Cartridge magazine. We have a long way out, but this is the always important corner, the exit of the alimentary limb here. So we cannot make it narrow here. Feel? Yeah. O que sabe? Tá? Feel? Tell me, what about the quality of the image? Are you happy with the image or not? No comments?
Agora vai.
Agora vai? Foi?
Você quer tirar? Still the same problem.
Pois. Ah, ok. Sim. Okay. Mais perto. Off. Stop. Focus. I don't test with the anastomosis. I've never done it since I began with the gastric bypass in 2002. So I never had a leak in this place. So when you see that the way out of the alimentary limb is okay, it's important because sometimes problems of pain and emptying problems and difficulties with in the can produce pain in the left flank of the patient. This is not the case. It will not happen in this case, I hope. Aqui, Carlos. Fechamos para depois. Carga. Essas bolsinhas são maravilhosas, não tem muitos instrumentos. Não fosse elas, não é? Puxa um bocadinho mais para cima. Não tem espaço. Ok, já passou. So. Now it's important here in this step to stay close to the GJ in order to avoid, let's put some angle into the machine to avoid the candy cane formation. Something like this is enough. I'm going to check the staple lines to look at to see if everything is okay. The first one is sometimes it bleeds a bit, and sometimes it bleeds a bit, but in this case, it's okay. Anyway, in the end, we used to put some fibrin glue, and I want to put some fibrin glue here because it's a potential case of salt, and this is our intermesenteric space. Aqui, Carlos, assim. I'm going to close from up to down. Taking a bite of bowel in order to fix it better. To fix, I need to block it, not to fix in the repair sense. Passa para aqui, Carlos. So the beauty of this technique, and I would say that I have nowadays about maybe 400 cases of diverted OAGB, is that we can get the same good outcomes about weight loss as the OAGB because we keep the long pouch and with more restriction, slightly more restriction, maybe mainly in the future, in the long run. And we have also a big biliopancreatic limb, a long biliopancreatic limb with more powerful metabolic effect. Those are the advantages, mainly to get the best of two worlds, dealing good with the weight, dealing good with the weight and with the reflex. Of course, we are going to have again an alimentary limb that is connected in the practice sense with the possible increased rate of hypoglycemia. And also this Espera aí, deixa-me acabar o que estou a dizer, depois já fazes. And also, again, the risk of internal hernia. That's why we are so careful about closing not only this space, but only the Peterson space, because we don't want to have too much hernias. And even this year we had one in a patient operated from 8 or 9 years ago. So every choice has a clear side and a dark side, like the moon. Diz, Vasco.
Do you think you could avoid the anti-bill reflex speech on the gastroesophageal anastomosis in case of diverted oxygen?
I suppose yes, but as I said before, even in a Roux-en-Y we can have reflux in the long run. So I suppose that if we work more, we are getting more better outcomes. So I prefer to do it, to thin by excess, not by defeat, not by defect. Did I answer? Understood? Pier Paolo. We have the obligation to do the best for our patient. The best really is to fix the hiatus, try to keep the esophagus down, try to avoid the migration of this tube upwards. Do the best as we can. In this case, a little bit large pouch, but she's 72 years old and she's only 29 in BMI. Consider this. Another advantage is the anti-diabetic effect. Would you be worried with this white area? Otávio? No? No, I'm not also. Neither do I. So what can we do more? I'm going to show you something that we do usually in diabetic patients. Carlos, faz-me aqui bocadinho esta pressão para baixo. Deixa-me só limpar aqui pouco. Remember, she is a diabetic patient since the beginning. When I operated her, the first time, she was diabetic for more than 10 years. Dá-me o ganchinho. Não. Mas tenho que perguntar, se querem saber. No questions about this? É só para ver se eles estão acordados. Ok. Cola? Sim, sim. Now we're going to put the fibrin glue. Yes, please. Okay. This is something that I learned from Ludovico Auri de Paula. In the operation that is ileal diversion with sleeve and duodenal cross, duodenal switch, which is a very good outcome, even in important diabetic people or long-run diabetic people. He improved these outcomes doing two things: the devascularization of the liver and pancreas, cutting the sympathetic fibers around the vena porta, the portal fibers, and the glucose sensors. You see the vagus there? Talking about nerve, the vagus is there. And also the sympathetic fibers that goes in that area right to the liver sometimes, some way. And so we need to cut those vessels and we can get a better anti-diabetic effect. It's not science, but he's doing that. Tá? Já, ok? Dá-me outra ponta.
Nunca teve, tinha agora. Não, não.
Apertou ainda mais. Quando é que faz anos? Eu vou fazer uma chave de fendas para treinar lá em casa. Sorry, I touched with the tip of the instrument in the tissues and it was blocked. Pode apertar, faz favor? Tá? Não está, não tem gás, com certeza, pá, não está. Pode ser, pá. Vá, carregue lá. Carreguem lá. Se calhar não tem gás.
Não tenho pressão.
Agora que viram isso. Ok, vai gota a gota, que feliz. Ok, I used to put the glue as a spray, but now I'm using like the drop to drop because I don't want to waste time waiting for the bottle gas exchange. Isso é que a gente experiente nestas coisas, não se podem ter neófitos. Água perfeito. Ok. Acabou. Sorry, because of the problem. It should be like a spray.
Okay, for this, ciao everybody. I have to leave.
Okay, ciao. We can end now here, and we'll meet in half an hour again in another room. Okay? Então temos as conversas primeiro.
Espero que agradeça.
Muito obrigado. É só uma compressa, não é? E a vesícula já lá vamos. Agora. By the way, I will not use drain. There is no reason for that in this case. And we are using, I would say, less than 10% or maybe less than 5% of the cases. Vamos retirar esta coisa. Desligar o gás ou reduzir aqui? Tem um buraquinho? Tira a imagem, tira a imagem. Ok. Tira o buraco, não sei.
É sempre para a transmissão, já.
Ok. Então estamos. Vou usar a sala, por favor. No, pode. We are going to break for a while and we meet in half an hour, okay? Vicua.
So we're going to proceed, and Dr. Otávio Veiras will present a small talk about surgical technique, tips and tricks in revisional OAGB. We have seen some of those issues this morning, but we are going to look at it in a more systematic way by Otávio Veiras, my main assistant and nowadays, and I hope you can enjoy also. Thank you.
Hello, everyone. It's glad to finally finish the DERA masterclass, which took us almost 2 years back because of this pandemic. and we're finalizing and should be presential, but this is the best way to give a final. And hopefully in the near future, we'll meet and have a dinner and talk about it. So today I'm going to talk about OAGB as a revisional surgery. First, my presentation has two parts. It's OAGB has a revisional surgery, and there's a second part, revising the OAGB. So we didn't have on the program, so I talked to Dr. Rui and the other colleagues, and they thought there might be a interesting issue. So we're going to talk about it, and it's about surgical techniques and tricks. So why to convert any kind of surgery, talking about weight regain and insufficient weight loss. And the other one, it's complications. Complications, they always they give us a lot of issues and a lot of problems, and they have to be resolved. Of course, you have to do have to figure out and do a proper investigation, not only to figure out the failure, but to understand the complication. Of course, you have to do a detailed clinical history, a physical exam, understand and consult your previous surgical protocol, and understand the bariatric procedure that was done before. Of course, you have to have or understand the new anatomy, the new physiology with upper GI, rebellion swallow test, or even if you want to, a 3D CT scan. You have to do all of this on revisional surgery. It's important, it's a must. It's a must do. You have to be on a multidisciplinary approach in all revision, not only OAGB, but in all bariatric procedures. Bariatric surgery in the last years have had recorded a steep increase in the last years, rising from the 6 to the 13% of all bariatric procedures. Conversion OAGB following primary restricted procedure, we're talking about sleeve and we're talking about band, have already been published, and there are some meta-analysis and systematic reviews on PubMed. Just the big question is how to avoid failure on a revisional OAGB. So the best question and how to ensure success and avoid failure is patient selection. Of course, you have to have the right patient and the right procedure for the right patient. This is a table that was presented on this article. It was Pediatric Practices Concerning the One Anastomosis Gastric Bypass. It was a survey of 2010 surgeons of Kamal and was published in 2018. And on this table, you can see these are the absolute contraindications to do OAGB, but for primary OAGB. As you can see, significant GORD symptoms of GERD, large hiatus hernia, severe esophagitis, and Barrett's esophagitis. These are the main absolute contraindications to do this kind of procedures. So if these are the main contraindications for the primary, of course, if you want to do a revisional and you're thinking about to do a OAGB, just think about it because these are contraindications to do so. But what can an OAGB offer when you're thinking about an OAGB as a revisional surgery? Perhaps you're thinking about to increase weight loss. Perhaps you're thinking about to control the metabolic effect or the comorbidities that the patient has. We're talking about hypertension. We're talking about diabetes. We're talking about dyslipidemia. Perhaps you're looking, as you all know, revisional surgery, and OAGB, it's not different from other ones. It has more complications, right? So you have to be ready to that. And OAGB, it's a good procedure because it has less complications compared to other one. Or perhaps you just need a technically easiness procedure, and OAGB, it's that procedure. So this is a good literature that is published about OAGB, revisional OAGB and revisional OAGB comparing with revisional Roux-en-Y. And the main, this presentation, it's based on this article. So the main reasons to convert to the main reasons of failure or in success is weight regain and weight loss failure. So AGB is good. It's a good procedure to override this obstacle that the patient has when he did the sleeve gastrectomy or the band. When you're talking about weight regain and failure, there are a lot of definitions, and when you go to the literature, you have quite a lot of weight regain definitions. On this one, the most used 1/3 was BMI below or percentage of excess weight loss below 50 or BMI of 35. So there's a lot of definitions. The one advice, just choose one and just use for all your works. Don't choose the definitions as you go along. So this is what we call on these studies failure. It's really important to have, I already told in the introduction, you have to do a multidisciplinary approach. Sometimes the best surgery or the best revisional surgery is no surgery at all. And probably you will have you will resolve the problem if you're talking about weight regain or insufficient weight loss with the dietist or the psychology, or just doing some medication to lose weight. But if you want to do surgery, don't forget, I already talked about it, there's a high complication rate. And if you want to take the bull by the horns, you have to be advised with a specialist or an expert, or else you will get the horns, the bull will get you by the horns. So try to avoid and to have a proper expert by your side, just like Dr. Ruiz said early in the walk. What are the main surgical technique and tip and tricks when you're doing? So this is about sleeve. You're already seen some of the steps that you have to get through. So you have to dissect all the gastric sleeve, the gastric pouch that we have. You have to dissect free from the firm adhesions that you have. You start at the staple line, distal to the staple line from the surrounding tissues, and go along until reach the angle of this. Careful not to ligate, and Dr. Rui already talked about it. Careful not to ligate important major vessels to the gastric pouch or to our new OEGB gastric pouch. Always calibrate your pouch. There's a good way just to see if there's dilation. We use it in 33, 36 French or 42. Don't forget that gastric pouch should always be at least 40 centimeters, but 15 it's a proper length. And we always try to use high stapler. So use sometimes if you feel that green is not enough, or just you need hemostasis, additional hemostasis. Just reinforcements if it's needed. Trim all the excessive gastric tissues along the new gastric pouch, and over suture or reinforced stapler that may be necessary, especially at the angle of this. So this is a little clip. It's similar to the video that we seen today. And so we have here our gastric pouch. And similar to what Dr. Ruiz did minutes ago, we're going to install it with a saline liquid just to see the dilation. And if there's some kind of stenosis, some kind of torsion. We see that on the surgery back minutes ago, there was some kind of torsion. There's some kind of stenosis at this side. And it was quite dilated, and we cannot see the fundus yet, but as soon as we started to take the adhesions off, we will see a dilated fundus. So just be sure not to injure your stomach, and be sure not to ligate major vessels at this step. So a little bit. And like Dr. Ruiz said minutes ago, always be careful, and if you have access to your surgical protocol, previous surgical protocols, just give a read and just see if there's any kind of clips. Here we seeing clips that were put it at the angle of this, just like we saw in the surgery. Be careful at this side, because you can, if you don't do this at this time, you may have a misfire on your staple gun. So always be careful at this side. Be careful not to ligate major vessels around here. Be careful with the spleen. So these are the main information, the main advices to you to have when you're doing this, when you're revising this kind of surgery. So at this time we did the back tunnel from the right, and sometimes, like Maximilian told you, the best approach just to do from the left, but here we did quite easily, so we didn't need to. But if you had any kind of difficulty, just go by the left side. Here we have a vlog from the previous surgery. Just try to remove these adhesions from your gastric pouch, just for don't have any kind of rotation. Be careful again not to ligate major vessels that might compromise your vascularization. Here is your dilated fundus, and here we're trimming our pouch for that we can have a long and a narrow tube. So this is the main advices when you're doing a conversion from slave to an OEGB. Another procedure that wasn't a lot of frequent in the past, it was band. And converting a band to OEGB has different issues, different difficulties. And the best one is when you're removing, try not to burn the stomach, of course, but don't forget to remove the surrounding capsule and the adhesions along with it. Remove the internal fibrous tissue between the band and the stomach. If you don't do this step, you will not prevent stenosis. Not only when you're trying to do the tube, you will have some kind of stenosis or some kind of torsion. Sometimes you may have any kind of leaks on that side. So I'll show you a clip talking about this. So remove a lot of the adhesions to the liver. There are a lot of frequency at this time. Always go on the upper side of the band, always on the so that you don't injure your stomach. Here it is. And don't forget to remove this circular tissue, or else it won't be. So we're just still removing, just trying to have our access to put our cartridge. Should go as low as you can at this side. And then we start to do our gastric pouch and arrow with 36 French tube inside. Just removing some adhesions. So this is what I was talking about. At this time, we just reinforced with some SIM guard just to have a better hemostasis and to try to avoid at this time, because of the thick tissue, to avoid the fistula. So these are the main steps when you're converting from a restrictive procedure to a OEGB. So what about revising an OEGB? Why to revise? So we know that 4% of the OEGB will need any kind of revisional or reversal of surgery in the long term. In OHGB failure, it's about 4.5% of weight regain, weight loss failure. So this is not an issue, but complications, it corresponds to 3.5% of the need to revision. And the main complications we're talking about, it's marginal at 2%, GERD 1 to 2%. It's not so high as most people think, or as much people talk about it. So, and malnutrition, we just have, it's around 1%, 0.7. So this is the an article published by Chetan, Parmar, and Kamal on 2018. And this is a systematic review with a lot of patients. And this is the main percentages of the complications that are associated with OHGB, primary OHGB. So we have more or less 2.7% of marginal, 2% of GERD symptoms. This is not GERD identification, but GERD symptoms, and a mortality of 0.1 and malnutrition 0.7. So how do we resolve this? How to revise this kind of procedure? Like any kind of procedure, as we has already talked about, it's important to have a multidisciplinary team. And when we're talking about weight regain, more than 10 kilo or more than 20% of primary weight, I use this definition. As you can see, definitions just change from offer to offer. And this is the definition used on this article that was published by Kemal Zarabi. And when we're talking about weight loss failure, it was patients below 25% of excess BMI loss. So the best procedure, if you have any kind of surgical indication, is just to increase your BP limb. But don't forget, as I already told in the beginning, but for most patients and for some patients, no surgery is the best surgery. So just have a reunion with your team and just try to have the proper decision. Leah and all just treated all these patients with either duodenal switch or just a BPD. Musella and his all revisional, more or less, it was 800 patients. 800 patients, 1,800 patients. Showed failure was correlated with a learning curve of less than 50 cases. You have to think about it. Try not to think that your patients are just your patients that complicate. You have a learning curve, and this might be the 50 cases. And most of these cases where Moselle had to revise, he did a loop revising and a pouch resizing. Most of the time when you're doing a loop resize, you have to revise your pouch. Just see, if you don't need to, if there's no dilation, you don't have to do. So this is a clip that shows exactly what I was talking about increasing the BP limb. This patient has 150 kilograms. She was operated 1 year ago, and she had a BP limb of 2 meters. So she just lost 50 kilograms, but she reached 100 kilograms of low weight, but she regained weight until she reached again almost 120 kilograms. So we had to revise and had to give some solution to this patient. Our multidisciplinary team just thought, and it was my opinion too, that we had to do some kind of surgical procedure. And the surgical procedure that we decided to was to revise our BP limb and to increase it. So remove all the adhesions to the anastomosis. So we have the anastomosis all freed up. And as soon as you go, we use the green cartridge. You have to divide it. Be careful not to put stomach around here. If you have to do, or if you do the cutting around here, you will have to revise and remove this stomach that's going to be on this bowel. So be as much as you can right in the middle, just confirm and check and recheck it again, just for you to have really in the middle. If it doesn't happen, you have to resect it from your small bowel, okay? And here you go. And we're going to invaginate these stitches, this suture line with a vicryl. So as you can see, it was quite easy to remove. Just don't forget what I talked about, not to leave stomach or residue of stomach on the small bowel. And we're going to give you 1 meter plus for this patient. She will be with a BP lamp of 3 meters. So the rest is just equal as a primary surgery. Just do your gastro-J anastomosis and you're all done. So this is how we revise a patient, an OHGB patient. And here he is, at least 14 centimeters. That's good enough. This is how we revise and how to increase your BP limb. It's quite easy to do, and without having any kind of complications associated with it. So, how to revise complications? These are the main complications that we're talking about. So we're going to start with marginal ulcer, and the best way to treat marginal ulcer is just to treat the condition that led to it. So we're talking about acid and giving PPIs. We're talking about just to see if the patient was in a smoker patient, if he started to smoke, and try to remove the smoking. And if the patient, and alcohol, don't forget alcohol, it's another issue. And if you have, and if you didn't have eradicated H. pylori, just have to do, and we'll have to do antibiotics so the best treatment for a marginal ulcer is just no surgical treatment at all. So it's the best treatment, the first line of treatment. But we wish everything was like that, and sometimes you may have resistant and a bleeder marginal ulcer. So, and in these steps, and this time you have to revise this procedure. And how can you do it? Just revising your anastomosis, conversion to a Roux-en-Y procedure, just conversion to a sleeve gastrectomy, and not so famous brown jejunostomy, but it's described in the literature, and a complete reversal if it's needed to. In cases of perforated marginal ulcer, there are a lot of procedures, as you can do Roux-en-Y, complete reversion, but sometimes just a suture with an omental patch, and drainage is more than sufficient. And I'm going to show you a clip perforated marginal ulcer that we had last week. So the patient did an OHGB 3 months ago, and a heavy smoker, and she presented in our ER with abdominal pain. This is her endoscopy with a lot of ingurgitation with a lot of edema from the mucosa. And this was our aspect, our gastro-J was quite black, and with the efferent limb with palish tone, and we thought we were dealing with an ischemic event. So we did the surgery in the same day. We took to do a OR, thinking it was an ischemic from our gastro-J anastomosis. As you can see, the tissues, there was no kind of internal hernia. Was quite fine. There were no kind of torsions. There were no ischemia, but there was here some kind of inflammatory tissue, and we're trying to understand what happened. At this time, we just understand that we had marginal ulcer with a penetrating, perforated, but not to the peritoneum, and we didn't have any kind of constriction. So what to do here? And since we didn't have any constriction from the abdominal cavity, we decided to do some stitches, some suture of this marginal ulcer, and we did it an omental patch. So, and the patient that had her discharge yesterday with no complication whatsoever in the last week. So this is just to show that it's a possible treatment as it was described in the article. And the patient just, sometimes the best solution for a complicated procedure is just the simple one, the simplest one.
Just to say that she came back to the smoking habit, and she left the PPIs for since the first month. So she was not making the prevention that was recommended.
Yeah, and so this is what happened. Not doing your PPI, starting to smoke again. She said that she's not drinking. She did have eradicated the H. pylori and with confirmation. So of course, no PPI in smoking. This would be, it was sooner, but it would be a complication in the near future. So, and this was our solution. The other complication, it's GERD. And I give you this table where you have the most, this is what was a systematic review of Kermanzaravi. And here, where you have the complications rate of GERD was between 1% and 2%. In most of the cases, when you can see there's an incidence of 2 to uppers, almost 4%, there was the risk factors for this. And when you can see where you have the short procedure, it's like Roux-en-Y. It has a GERD or GORD symptoms rate increased when you're doing revisional. And in case of Dr. Buzelli, that's a quite experienced surgeon. In this case, he had a 2% incidence, and it was, in some cases, he had a preoperative GERD that was not addressed. And there was a short gastric pouch inferior of 9 centimeters. So what we can learn of it, this is a systematic review. What we can learn of it is that you have to be careful when patient selection is important. And when I'm talking about patient selection, if you have that esophagitis grade C or B, if you have giant hernial hiatal hernia, if you have Barrett's esophagitis, Barrett's, don't do an OAGB. So just address that issue and try to avoid the complication. The other, it's a surgical problem, the surgical technique problem. You have to have a gastric pouch at least of 14 centimeters. If you have a longer one, you will be you will have a proper shield to avoid GERD in the near future. How to revise GERD? Most of the times, just have to, if you cannot give PPIs and the proper dietary plan to avoid, try to avoid food when you're going to sleep, try to avoid some kind of nutritional, some foods that can avoid that. But if you have to revise, how to revise? Just transform it to the derived OAGB. How to do it? Just count. We do it normally 1 meter of elementary limb, and we just do our intra-anastomosis, as you've seen already today. This is the best way if you have any kind of GERD after a OAGB. The most procedure, the best procedure for most authors when you're doing conversion of OAGB because of GERD is to convert to a Roux-en-Y. This is the type that we do. The other complication, malnutrition, 0.7%. Rutledge and Walsh reported on his 2,400 patients with OHB 1% of excess weight loss. So, and on 31 cases, they all underwent revision to reversal to normal anatomy. Carbajo and Chevalier did not perform any kind of reversal operation for this kind of patient. They only did on a multidisciplinary approach basis, and they manage the malnutrition just to do the proper multivitamins, and that was all that was to correct this problem. If you have on a surgical indication on your multidisciplinary approach, reversal in decreasing your BP limb or conversion to normal, they are all valid solutions. So take home messages, revisional OEGB after failed restrictive bariatric procedures is feasible and effective with low complications. One of the most important advantages of OEGB is its simplicity of reversal, and its revision makes this procedure safe and more popular. Don't forget, when you're doing complications and when you're doing revisional surgery, just be advised with a specialist or an expert in the matter so that your procedure may have all the security that it needs and it needs to, and for the results be the best. So this is all that I had to talk about today, and I hope you enjoyed, and I'll be here for your questions.
Okay, so we are now waiting for your questions and possible commentaries or vamos pôr em direto os presentes. Ora, aí está. So I would like to say that Otávio has made a very good revision of the topic. Of course, the topic of the revision of OEGB, how to construct it, it's not different a lot from the primary OEGB technique. It has the same steps, but it has the additional steps of adhesiolysis and the preparation of the pouch and the hiatus, it was the case today, for to construct the operation, the OEGB. Of course, there are a lot of technical details. He has made a review of most of them. We have seen other ones in the morning, and maybe if you have time, I can show you some other clips with other issues that we have not addressed yet. But by now, I would the quality of the second part of the that was dealing with how can we revise the education. So I would like to have something. Oh, okay, are you listening now?
Yeah, yeah.
Someone? Okay. Paul. So are you listening well and seeing well?
Yeah, I was listening. I had some lag in some times, but now I'm listening very well.
Yes, there is some instability of the net, maybe. Anyway, another comment I would like to introduce here is that we are talking about failure of the sleeve, failure of the band. And some surgeons, they consider that this is not really a failure because we are dealing with a chronic disease, and the chronic disease have different steps and they are evolutive. So the treatment sometimes is different for the different stages of the disease. So when we perform a restrictive surgery, it will be a previous step, and there is a progression of disease later on, and we should not call it failure. Anyway, somehow it's a failure. Making an analogy with other specialties, with cardiology, for instance, we begin with one medicine for the heart, and after that, two medicines, a different one. Later on, we need to put a stand that the pacemaker, the stand before failed, or that the drug failed. It's somehow this kind of discussion. What do you think? Dr. Ginosati, I'm seeing you. Good to see you again. You have been with us in the last course.
Yes.
Are you listening now?
Yeah. Another lag in the last minute. However, I was asking you about the stitches between the duodenum and the terminal part of the gastric tube before when you were operating, not on the upper side between the esophageum and you know I made you a question meanwhile you was operating if you could avoid the anti-bile reflux between the omega limb and the tube in case of diverted. You know, you don't have more reflux like here. I think you can avoid that stitch, maybe.
Which stitch? I didn't touch the duodenum today.
Ileum, the ileum, the intestine.
Aquele ponto de carvalho.
Do qual? Okay, but in the new greater curvature.
Yeah.
Okay. It can avoid some kind of torsion, maybe. In that sense, it can prevent reflux. We do it usually, regularly, when we are performing the OHGB, but with the diverted OHGB, the risk of reflux is increasingly diminished. So it's very, very low indeed. Because we have a good emptying of the gastric pouch, we have a long biliopancreatic alimentary limb, and it will be difficult to have bile reflux 1 meter alimentary limb. In the beginning, when I began with this operation in 2013, I was performing an alimentary limb of 60 centimeters. And I had at that time 2 cases of reflux with bile. Patients were complaining of heartburn and sometimes with bile. And because of that, I increased it first to 80 centimeters and later on to 1 meter when I went for the literature and found that the best measurement, the best length would be 1 meter to avoid. The stitches in this operation, well, they make sense in the OHGB because there is a risk of torsion of the omega, but with the Roux-en-Y, there is a straight line, there is only one tube pulling down the pouch, and of course it's not risky not to put the stitches. I put the stitch just to defend the corner because sometimes those staples are not well closed and it's a potential place for a leak just because of that.
Of course. Thank you. I think I'm the only one remained to observe you. Is there anyone else of the course? And I'm the last.
Maybe make a challenge to Massimiliano, are you there? Greco.
No, Greco told he went.
He went? Quem? Dr. Fuzia, any comment to the Octavio's presentation? Any doubt? Connect your micro, please.
No. No comment, no question. Congratulations.
No. So let me put you one small question. Do you think that the narrow pouch, the narrow and long pouch, is it really important to the weight loss or not? Or can we, because we have two lines of thinking. The Spanish school with Carbajo and followers, between them, myself, we think that a narrow and long tube is important because it's more restrictive. We have a slight restriction, a bit of restriction, not very important, but still a bit. And we think that this is important for the weight loss, for the weight maintenance in the long run. After 5-10 years, it's not easy to keep the weight low with a narrow pouch. But other people like Carbajo, Jean-Marc Chevalier, Goulart, and Indian guys mainly, or Mohit Bhandari, they do a larger pouch. And they say it's not important because the weight loss will be the same. It depends more on the length of the biliopancreatic limb. What is your interpretation? Are you more connected with the Indian concept or the Spanish or Rutledge, the American concept, or the Spanish one?
I prefer to perform a longer pouch, but smaller.
Narrow.
Because I think that it, yes, a longer, but
yeah.
do you understand? Okay. In my experience, I perform always in this way.
Good. I should say that there is one prospective trial performed by Fried Berens and this team in the Netherlands, and they compared Brunnwey gastric bypass with the same limb lengths, but with one arm with a short pouch, and another one with a long and narrow pouch, like in the OAGB. And after 3 years, there is a significant difference between the two pouches in favor of the long pouch. So I believe there is a role for a long and narrow pouch.
I think that another point is the protein intake, and maybe Carbajo make a larger pouch to avoid malnutrition, protein malnutrition, like Scopinaro in his duodeno, in his BPD did, with a larger part of intestine avoided. I saw Carbajo made 60% of biliopancreatic limb and 40% of common limb. So maybe he's worried about protein malnutrition.
No, maybe Rutledge is worried about that, and the Goulart and the other ones, because Carbajo does it, well, it's not very narrow, but does it narrow, that's not an issue. And mainly because we need to consider that we are in different countries, and in Iberia, in Spain, and Portugal, we do eat a lot of protein. So it will be difficult to get in protein deficiency unless you have a very aggressive surgery. And the people with a narrow pouch can still eat a lot of proteins, not properly bovine meat, but pork, chicken, lamb, they can eat that kind of meat, and of course even codfish, and of course also leguminous, grains, beans, they can eat all that. It's different in India because they are mostly vegetarians, and in those cases I accept that they perform a larger pouch because they need to eat more, but they will eat more starch, not proteins probably. And there is another issue. With a larger pouch, you are going to have more acid, and with more acid, we are more prone to have a reflux and esophagitis and Barrett's in the future. Okay, so it's not, but this is a question that is not answered at all yet. Massimiliano, we are now there. What is your opinion and are you in favor of a long and narrow pouch or of a larger pouch?
I'm agree with the longer pouch, not large, but longer. I usually stay just straight to the bougie, okay, very close to the bougie, which is 40 French, so it's not so thin, but not so large. And yeah, and sometimes I make with the roulotte, I cover the suture, okay, so to prevent bleeding or fistula, something like this. But I have a question about that is not about reflux, but is about how patient feels after the OAGB procedure. Sometimes not so much, just 3-4 patients in a cohort of 100. They say that after 6 months, one year after the surgical procedure, they still have diarrhea. Okay. What do you suggest in these cases? Also, if I was very precise about calculating the length of the limb, and I'm not afraid about I've done something too much malabsorptive, but what I can suggest to my patients.
Sure. As Octavio said before, the best treatment is prevention. So if you have a patient that, for instance, is not able to come up to the follow-up with our nutritionist, and mainly nutritionist and psychologist maybe, but mainly nutritionist, that patient should not receive an OAGB. Because indeed, in real world, we know that there is a bowel adaptation that takes 2 or 3 years to happen. So during the first 2-3 years, the villi and the microvilli in the bowel in the absorptive limb will suffer an hypertrophy and hyperplasia, and it will increase the absorption capacity. Afterwards, it's the reason for some weight regain in all the surgeries, mostly in vulvar gastric bypass also. And it can happen also because we know that with OAGB, lots of patients, they increase, they recover weight, they have a weight regain. Not so important, but some weight regain after that time. The people with important weight regain are very few, maybe 2-3%, but it happens. And the reason are dilation of the pouch that happens sometimes, mostly in larger pouches, of course. That's why the long pouch is better in my view. And second, because of the compensatory hyperplasia of the bowel that will improve the absorption levels after 2-3 years. In the end of the first year, that process is not ended, it's running. So what we need to do is to support the patient as much as we can and to counseling him to eat a good amount of proteins, eat a lot of yogurt, take probiotics and mostly prebiotics, non-digestible fibers, it's very important, and give them sometimes some protein supplements for a while. Explain that this will be good in 2-3 years. Carvalho explained this very well because it's very aggressive and he has a lot of patients that he needs to support. And of course, there are some tricks about that. Try to reduce the bowel movements using more viscous food, gelatin, for instance, albumin, and with drugs. We can give pancreatic enzymes, okay, that will help a lot to increase the absorption of fat, because sometimes diarrhea is not because of malnutrition, it's just because of the transit is more quick, more rapid, and the fat will reach the colon, and fat is cathartic in the colon. It is that fat that will provoke the diarrhea. So if we increase the absorption of fat, we are going to have less fat in the colon and less diarrhea. It's very important. But be attention, we need high doses of pancreatic enzymes, something like 450 milligrams 3 or 4 times a day, mainly during the meals. And we can give also some kind of low pyramid to reduce the bowel speed, transit speed. And those are the tricks we can use, and proteins, and reinforce the proteins intake. Support the patient, and they will get. I can tell you a story of many years ago. I have done a urinary gastric bypass in a family that I operated the mother and 3 children right now. But at that time, I was only the woman, the mother. She had a band. First of all, I converted to a urinary gastric bypass. She was good about weight, and she has regained like something like 50 kilos after urinary gastric bypass. And she was asking for help, and I revised it. I made a destabilization of the urinary gastric bypass, and this was about 15 years ago. And she went from, I suppose, 120, she came up to 50 kilos. She was apparently malnourished. And I resisted. I didn't operate on her again. I supported her with proteins, with this strategy. And in 1-2 years, she recovered very well. And she's still thin with 70 kilos nowadays. I saw her 2 or 3 weeks ago with her children that operate. So we need to support them. And if we support it, give time to the recovery, and it will work, at least in the majority of the cases. Of course, there are exceptions, and sometimes we need to go for the revision, but generally we can try it.
I just want to add a comment to you, Maximilian. Sometimes at 6 months, everything's normalizing, the patient food and the gastrointestinal bacteria normalizing. And when you're doing that, sometimes you had what we call the dysbiosis. And we do in some patients, when we just how do we say we have an investigation just to see what they are eating, and if they're eating proper food, we just advise to do the probiotics like Dr. Ru said, and we do antibiotics, metronidazole for a whole week, 500 milligrams every 8 hours, 1 week. Sometimes that's just more than enough. It just gives a reset to the colon bacteria flora, and you just repopularize with probiotics and prebiotics. If the patient has more than 3 or 4 diarrhea events of diarrhea a day, sometimes probably you could have to revise and reduce the BP-LEM. So, but that's just a small % of the patients, okay?
I don't know if you are very familiar with the prebiotics concept. Those are fibers that are not digested and that they will reach the ileum and the colon. And they are very, very important because we know that those bacteria, they belong to the good families of bacteria in the colon and in the ileum. We are talking about Bifidobacterium, Lactobacillus, and Bacteroidetes. Those 3 families, those 3 kinds of bacteria, they are the food for the fibers are the food for those bacteria, and those bacteria, they produce the short
fatty acids.
Fatty acids. They are, I talk about butyrate mainly, and butyrate will have a very, very important good role about the enterocyte. It will improve the connections, the impermeability of the bowel, avoiding translocation and avoiding even the absorption of non-ramified, the other fats, the bad fats. So it diminishes the fat absorption, and it will increase the production by the L cells of GLP-1, and it will improve and maximize or optimize the role of the biliary salts that by the hematogenous way will act in the bowel producing the GLP-1. So it's very important to have those kind of bacteria, and it's not, nowadays the concept is not to put the bacteria there. There are lots of probiotics with lactobacillus, bifidobacillus, or bifidobacterium, but really they reach there, and if they don't have food, they will die. So the best way is to give the food. The ones that will remain there will grow up and make new colonies and improve the microbiota. So that's the concept of the prebiotic fibers. Mainly the
starch-resistant ones.
Excuse me. Have you ever some cases of dumping syndrome?
I have a couple of cases with dumping syndrome. I mean hypoglycemia, because there are two different concepts. The early dumping, it's a vascular event. It's some patients have it, but not so importantly as in Roux-en-Y gastric bypass. But about hypoglycemia, it's very, very different indeed. I've been performing Roux-en-Y for 9 years, 10 years even, and I had a lot of cases of hypoglycemia. Indeed, in reality, it was because of that problem that I changed to OAGB, because at that time I was asking to the people that were performing, I'm talking about Carbajo, Garcia Caballero, Jack Kimpens, Roberto Taquino, Rutledge himself. I asked them, are you having hypoglycemia with this operation? They said, no. And I believed them. And I went and really, we have some cases, but I would say 2, 3, 4 cases, but with slightly symptoms, very, very discrete, not important in the clinical point of view. Okay. Another question, I would say. Any one of you are performing the SADS operation? The single anastomosis duodeno-ileostomy with the sleeve from Sanchez Pernaute and Torres? No.
Yeah, just one time.
Just one time. Do you think it's a different operation from an OAGB? It's a very different operation.
It's not very easy, very different. The only difference that I find that I make the suture by hand and not with the carriage.
That's it. No, that's because okay, we are in Portugal, close to Spain, and I'm a lot of times with Sanchez Pernaute, and we do agree that we are making the same kind of surgery. Look. My rule for diverted OAGB or for OAGB is to have at least 3 meters of absorptive bowel. I mean, a common limb of 3 meters. And with that strategy in Portugal, with the kind of support you can offer to the patients, we are not having problems of malnutrition at all. But if you go for 250 or 2 meters, for instance, I know that Francesco Greco is more aggressive like Taquino, and he's going usually for 2.5 meters of absorptive limb. We can be at risk for malnutrition, of course. And look that with SADS, they make the opposite way. They began with 2 meters, they had malnutrition, they went for 250, they had malnutrition, and they are now in 3 meters. So we have the same minimal rule for the absorption. And of course, with the OAGB, if they can do it with SADS, why can't we go further down with OAGB? That's because we are doing here, usually, we measure the bowel, and nowadays we try to do it in super obese people, 50-50, 50 for the biliopancreatic and 50 for the absorptive. People between 40 and 50, we do it 40% for the biliopancreatic and 60 for the absorption, and only in low weight people, BMI below 35 or below 40, we do it in 150, 180, 2 meters. So we are more aggressive, but always with 3 meters of with the absorption capacity. So we have in the end the same rule as SADS, so it's not so different. What it can be different is, of course, the bile reflux, if the pylorus will work after SADS, which is not proven at all. And there are some reports saying that at least 30% or 40% of SADS, they have bile in the stomach in endoscopic evaluations. So that's why I was asking. It's not so different. And nowadays we have people like Goulart, like the English people, Sheetan Parmar, Mahawar,
like Chevalier, they are advising to perform only 150 of the ileopancreatic limb always. Okay, it's safe, it's more safe. Of course, they are not going to have big problems with malnutrition. And but for sure, some of their patients, after 5 years, they will have a weight regain. Afterwards, my interpretation is Carvalho technique and more aggressive techniques are trying to get a patient with a BMI of 25 after 10 years. And the ones with the 150, they are trying to get the patient with a 30 BMI after 10 years. So it's more ambitious, I would say. So we need to consider that aspect. Another question, do you think that malabsorption is the same as malnutrition? Per Paolo, malnutrition and malabsorption.
Here I am. Malnutrition is where when you have hypoproteinemia, micronutrient deficiency, and malabsorption maybe not
be able to absorb
with this. So
that's because Carvalho said comments on this many times. Because look, if a patient with a Roux-en-Y or OHB is not eating well, if he's not eating proteins, sooner or later he will have some hypoproteinemia, maybe anemia, because he's not eating. Because if they eat properly, in OHB with 3 meters, we are not having malabsorption. And of course, if people eat well, they are not having any kind of complaints of malabsorption. But I had a patient, I suppose, 3 years ago that I performed OHB, and she has got 45 kilos. She was really, really tiny and thin and not with a not pleasant image, very, very cadaveric, I would say. And I was studying her. She was a workaholic woman. She was working 14 hours a day. She was smoking 2 packets of cigarettes, and she was drinking more than 10 coffees and not eating. Was the fault of the operation or of the patient? What have I done? I didn't wait for the malnutrition symptoms, for the malabsorption symptoms, for the hypoproteinemia, and I decided to revise her before that could happen. And I went for a reversal, for a not to the normal anatomy. I suppose we are not doing that. We are doing a Magenstrasse Mill operation. That is a restrictive operation. And afterward, she's still with 48 kilos. So with the reversion, she is not. So it's a proof that it was not because of habit. What do you think about this?
Terrible. And what about the iron deficiency in your cases?
We try to follow as much patients as we can. Of course, some of them are not coming, but I suppose it reduces the percentage. And we have our protocol with labs 2 or 3 times in the first year, 2 times in the second, and 1 time a year. And we have some cases with slight deficiencies, but it's not important nowadays. We are not giving endogenous iron to the patients anymore. Only 1 or 2 cases, and even nowadays I'm receiving patients with that problem, but from Roux-en-Y gastric bypass, the older one. Mainly, and an important factor is the way as we give supplements to the patients. From 4 years ago, 3-4 years, I adopted the, forgive me the advertising, but the Fit for Me supplementations, and they are very complete, and patients accept them well. And it's very important, I suppose, to avoid the iron deficiency. But of course, we counsel them to come to the dietitian, and they come. And of course, they are eating good proteins and red fruits and so on in order to avoid the problem. We have some, but not important cases. Okay, I suppose it's time to go forward, and I would invite Dr. Carlos Trindade to speak us about the outcomes of the revision of OAGB, okay? And we can talk more after this.
Consegue pôr isto? São três.
Just a moment.
São três. Então,
já está a partilhar?
Não. Acho que é vantagem essa, veja lá. Não, essa não. Essa é a Regional Tips and Tricks.
É melhor abrir de novo a outra aí.
Isso. Essa são três. Esta é isso.
Okay.
Here we go. Okay. Hi, everybody. It's nice to be back to OHB Masterclass again, finally. So there are some points Otavio already told us about, but what are we talking about when we speak about revised previous bariatric surgery? We must stress the why to revise or convert, normally failure. But Otavio already told you also, be aware of different definitions of what is failure, what is weight regain, and complications. Investigation of the etiology and failure of failure and complication, it's with clinical history and exams, and the multidisciplinary approach for all revisional bariatric surgery is important. We must study the patients before we try even to perform a surgery. Não posso falar muito mais rápido. Mais alto. Well, these are the surgeries we are talking about, and we know Chetan Parmar from England, from London, already stated it recently that one anastomosis is in a systematic review is an established bariatric surgery. We already know it. These are 1,200 patients, almost 1,300, with a follow-up from 6 months to 12 years, and big studies, more than 1,000 patients each study, and with great results. So good outcomes. This is not new. And the conclusion about there is enough evidence to include MGB or OAGB as a mainstream bariatric procedure. So we also know that recently IFSO updated its position statement on anastomosis gastric bypass, and we know the review 120 studies, 23,000 patients. The studies were 9 randomized, 86 non-randomized, and 15 review. They performed 95 quantitative syntheses and 15 qualitative syntheses in the review and meta-analysis. 41 studies approach revision or secondary procedures, and they had a follow-up of 1 year 86% and 5 years 55%. And they recommended that OHB in the primary setting provides better weight loss, better comorbidity reduction, and fewer complications than if performed as revisional. And we should inform patients about these differences, but it does not say we can perform OHB as revisional. So OHB is an accepted bariatric procedure by IFSO and almost all the world, is increasing its numbers. Revisional bariatric surgery is increasing also from 6 to 13% last years. And we know that revisional OHB following primary restrictive procedures has been published with good results. What do you want to achieve with a revisional OHB? Increase the weight loss, a better metabolic effect, treatment of GERD, less complications, or just a simple surgery, simpler surgery? Well, Otávio told us about the two main studies that we have today about this subject. This one of Karman Sarabi from Iran about OHB as revisional following primary restrictive surgery. So he searched international databases until September last year, 2020, and he found 26 studies, 170 patients after restrictive procedures, and performed a meta-analysis on sleeve gastrectomy, laparoscopic adjustable gastric banding, and vertical banded gastroplasty. No of the studies were randomized control trials. All of them were retrospective. So we can see the studies after laparoscopic sleeve gastrectomy, not much numbers. The bigger one from Mario Musel with 100 patients. After gastric banding, lots of studies, some of them also with 100, almost 200 patients, some of them were comparative, like this one from Pujol from Spain with 190 patients. This was a multi-center study which our group also participated, or Dr. Rui Ribeiro patients were included. And after vertical banded gastroplasty, is still in debate what's the optimal limb length for primary and revisional, but some studies use 150 and increase by 10 centimeters each point above 40. It's controversial. It's a point of debate. We already don't know. Dr. Rui have been talking about that some moments ago. We can't have certainties about what's the best. In some studies, we had we had comparable outcomes with different BP limbs. Maybe the dietary problem issue is important in this result. And the other paper about with Jaime Tovar and Miguel Carvalho, that with the a channel of 200 to 220. So it's even different of what we make with a common of 300 to avoid malnutrition. Well, a recommendation we can make is always, as we've seen in the surgery, always measure entire bowel, and if you have any doubts, go at 1/3 maximum for BP limb. The weight loss outcomes in this study at 1, 3, and 5 years, the mean initial BMI was 45 and decreased to 31, 31, and 30 at the 1, 3, and 5th year. And OAGB achieved a weight loss, effective weight loss, showing that he has acceptable and durable effects, at least at 5 years. After 1 year and 3 years and 5 years, OHB always showed most effective than gastric banding and sleeve gastrectomy in decreasing BMI. Comorbidity issue, we also had a good result in remission of type 2 diabetes with 65% at 1 year, 65 at 3 years, and 78 at 5 years, and the remission range from 40 to 88 and at first year, and 62 to 90% at 5th year. Hypertension, also a good remission, a good percentage of remission, 68, 49, and 74% at 5 years, also different ranges. Dyslipidemia, stand up attention. Also a good rates of remission at first year 61% and 5th year 85%, with also some difference in the range of remission according to the studies. Obstructive sleep apnea also got better with 80% to 86, and also a good remission, not so different the range of remission in this case. Talking about GERD, an issue for OAGB, whatever primary or revisional, we have always a good result reducing GERD. The results showed 81% of patients improved or had remission, but there was 7% de novo GERD following OAGB. So not much different from primary, a little bit more. There are also complications from revisional OAGB, although it appears to be more feasible than Roux-en-Y and other procedures technically more difficult. And the main complications were leakage rate of 1.6, just a slightly higher than from primary procedure, a bleeding of 1.2, comparable to primary, and the hypoalbuminemia rates 0.2, with most studies a BP limit of 200, not significant. Well, the other study is from Singapore, from the Tan Tock Seng Hospital, and is recent also, and made a revisional, a meta-analysis in comparison with Roux-en-Y. They search also international databases until February 2020, with 21 studies, 5 were comparative, and 1,300 patients. After restrictive procedures also, and no randomized control trials also, there's a problem about that, and they made the meta-analysis on sleeve bend and vertical bending gastroplasty. What they found that after revisional anastomosis, there was a percentage of excess weight loss of 76% at 48 months post-op. That decreased to 68 or 69 at 5 years. That's a good result also. On comorbidity, they found also type 2 diabetes 74%, 75 almost, hypertension 48, and dyslipidemia 63, and obstructive sleep apnea 75, comparable to the other study in terms of resolution. Metabolic syndrome resolution was also comparable, and a drawback of this study or this surgery, whatever we can call it, that revisional one anastomosis group had higher incidence of anastomotic ulcers, from 17% to 9.5. This study about the GERD outcomes, they found symptomatic bowel reflux of 6%, with 0% for Roux-en-Y. And they stress that although there is a clear difference between acid and bile, the risk of GERD and or bile reflux after primary and revisional is debated, and we really don't know if there is a real problem, because we can fix it with another surgery. In this study, they found only 3 studies reported the de novo GERD and bile reflux in patients who had no symptoms before, and they think that the main problem was the defective surgical technique, mainly a short gastric pouch or an hiatal hernia not detected. As you can remember, short gastric pouch was one of the problems in the United States for confounding OHGB and not to be allowed to be performed there. In conclusion, of these 2 studies, we can say OHGB as a revisional procedure after failed restrictive surgery is feasible and effective. Regardless of the BPLM, conversion to OHGB induces further weight loss before the so-called failed, if we call it like Rui told us, this is a chronic disease, so it's really failure of it's the normal course of the disease. There's a difference of concept. And we had remission rates of classic obesity-related diseases is satisfactory, and complications, post-op complications, are comparable to of primary OHGB. If we compare OHGB with Roux-en-Y, OHGB, revisional OHGB, maybe it's more simple to perform, and there's a shorter operative time. So I always, in these sessions, I always end with this slide. Don't forget standardization. We have to try to make the procedure always the same way. We must, and this is stressed by IFSO, and always register our results, our technique, our measures, evaluate what we done, compare with other people, and evaluate. This is all the people from this course, from the other sessions. Thank you. And if you want to make some questions, feel free.
Questions for Carlos?
Any questions? Hi, Fuxia.
No questions.
No questions.
I have a question for you.
Okay.
Because I don't know, because Carlos, as I told you, works in another hospital in Setúbal. I don't know exactly what he's performing in his daily practice in his hospital. I'm not asking about that. I know what he's doing here, not there. What are you doing in favorite bands? We had a lot of bands in Portugal with, in my case, hundreds of patients reoperated, revised. You have a lot for sure. What do you do in the favorite bands? Or And are all the bands the same situation, or do you think there are different situations for an OAGB? Would you indicate a OAGB in all the patients, in some patients, or in no patients?
Well, we performed a lot of bands. We started like everybody with bands, lab bands, and we have the same problem everybody has. People like food, and they don't get straight to the dietary plan. Another issue is complications of bands, and we have to remove bands for complications. It's another problem. We always study patients before trying to decide what to do. And as we do in primary surgery, we always use the alimentary pattern, the way people eat, if it's a volume eater, a sweet eater, and we try to adapt the surgery to the patient, at least to the way people eat and his comorbidity. So we are still performing surgery in patients we think it's worse to perform. Some patients we think they don't let's say it this way, deserve it because they won't be committed to that, like to another surgery. But we always remove the band first. We're still on that. I know there's some questions about that. There's some studies saying we can make the surgery in the same time, but we always take the band first. We wait. We have the multidisciplinary approach of the patient. We insist with that. And we are no longer performing sleeve gastrectomies after removing bands. We have some MGBs or WGBs performed after lap bands, but because of some reflux, maybe shorter pouch. That's not much patients, but because of some reflux we had, and we have to convert some to Roux-en-Y. We try to perform after bands. We perform Roux-en-Ys, long pouch even, but the double anastomosis procedure.
Okay, I just disagree with you about the removal of the band. We can do it safely in one step. It depends of the expertise of the team and of all the setup. Well, but coming back to my question in a more clear, just yes or no answer. You have a patient with a band that was put 10 years ago. The band is in a good place and he has a weight regain. What do you do? Which technique do you choose for revision?
For revision, just for weight regain.
Just for weight regain.
Well performed, I can perform a OAGB. If I do it technically correct, okay, if I have the possibility to do it correct,
good. That's no more consideration. If you have a guy with a band that was put 2 years ago, he has a huge slippage, a big pouch above the band, and the band is in the different orientation. He has a complication. He has an important esophageal dilation. What are you going to do?
First, I have to know if there is...
and there is no weight regain.
Okay. I can perform a OAGB also. I suppose. But I have to know if there is esophagitis or any complication of the...
Sure. Usually those patients complain of a lot of heartburn and vomiting because there is an esophageal dilation, and at least because of that there is an esophagitis, not necessarily by acid, but it can be by stasis, stasis of esophagitis. So in that case, it's better to perform a Roux-en-Y.
or divertics.
And if you have both together, weight regain and reflux and esophagitis grade A.
With hiatal hernia or not?
I'm pushing it, sorry.
Hiatal hernia or not?
With a small hernia like today.
Okay. Some weeks ago, I did a procedure almost like this one. I didn't perform it diverted. I just made it repair of the hernia, and a MGB with a long pouch. It was a conversion from a sleeve also, a small weight regain, not much weight regain, and some clinical uncomfortable reflux. I treated the hernia and made a WGB for this patient. I can do it also. She's okay now. She had another problem, but that was another problem. She had after the surgery, she had ulcer of the antrum, and she had a perforation at the first week post-op, and was a nice case to treat. She's okay now. And ended with an enterectomy.
Another difficult question for you. You are not my friend. You have a patient with a sleeve with some weight regain, not so important, 25 kilos. And in the endoscopy, they found an important gastritis and a chronic gastritis with atrophic mucosa. What are you going to perform?
With metaplasia or not?
With some metaplasia, can be.
Okay. RNY with gastrectomy.
With resection.
With resection of the resectional
Okay, second option, an extra weight loss, yes. And we can control the mucosa by endoscopy. That's another thing that we are performing here. We are doing some kinds of transit bipartition with 2 or 1 anastomosis, more with 1, because it's more simple. In most of the cases, feasible. And even for revision of a sleeve, it may be a good option. We need to think about that. By transit bipartition in 1 anastomosis, called SAZIG, or OATB, 1 anastomosis transit bipartition. And I would say that also, please don't forget that some patients are not operable unless you are able to perform a brain transplantation, okay? That can be, maybe in some patients, the best operation.
Do nothing.
Don't do nothing at those cases, of course. So, any questions? No more questions. So, in that situation, I would propose you to take a look on some other clips. We have about 20 minutes to finish the session. And, aqui está o STC. Tá bem. And I am going for a short series of clips that I prepared for you. Let me just find the file. Fechar esta aqui para não haver confusão. Agora está aberta, agora não sei. Passo-me agora para compartilhar a tela. É aqui na mesma. So this is a complementary presentation for technical tricks that I'm going to show you. And just to comment on some techniques that we have not, some issues that we have not, haven't seen today. So this is the case of neo-greater curvature dissection. And we can see there is also here a kind of a stenosis. And that patient was complaining of reflux, indeed. And we have done similar to our patient today, the dissection. And you could find that in that area there was really some fibrosis. So the message here again is keep a little bit away from the gastric wall, avoid to burn it, keep the important vessels, try not to produce ischemia and necrosis. And if you are in trouble, go further down. You see the pancreas in that area there, and go upwards. And try to find the landmarks like the left pillar. So this kind of standardization, Carlos just told that, is important. And coming back to the morning joke, we need to have a plan. We need to think in the situations. We need to have a strategy. Don't go for the improvisation that sometimes it cannot be. It can be not safe, and we can be with some problems. Okay. This is similar to today's work process. This is a video of how to remove a band. I can tell that I put more than 800 bands, and I have removed more than half of that, 400. So this is the more difficult step usually, to divide the adhesion between the pouch above the band and the stomach below the band. Sometimes it's very, very tight, the adhesion, but the trick is to go over the band, and sometimes can happen that you open the stomach. I just asked you, please open the stomach down the band, below the band, not above. Because we know how to suture and we know how to fix a hole in the stomach. But in the pouch, it can be tricky and risky because usually the pouches have a tiny gastric wall, and it's not so safe to close it. And go up to the left pillar with that job as much as you can. So this is the main message for this step in the gastric band. This is what we have seen also. Try to define your left crest. Sometimes it's easier to go to the left crest first, like in the hernia treatment. Usually it's easier to go from the left, but for small or medium hernias, it's easier to go by the right. And what is important is to find the right plane between the crest and the esophagus, not burning the esophagus again, not opening the pleura, and not destroying the pillar. So we have different requirements for this step, and we need to think about those boundaries of our actuation, of our performance. Keep it in mind. And here, it was not an easy pillar, but in the end, we could free it properly. Let's go to the second one, to the next one. Otávio just show something about this also, because sometimes we remove the band, but instead of the band, we are getting a dull ring of scar that we call it desmoid tissue. And if you don't remove that scar, the patient can be still with reflux because it's too much tight and can induce high pressure above, and if not acid esophagitis, stable esophagitis at least. So, and it's important to remove at least 1 or 2 centimeters of that circular scar in order to avoid a bypass with a band. Some people are doing that. They are converting sleeves to OHB with a band. I've tried it. It's better indeed, but some patients, they have a real difficulty to eat proteins, and we want them eating proteins. So I quit from that kind of technique of OHB with a band. But I've tried it, and the outcomes are good for people that are able to understand the requirements, and they are compliant with the work of the team, mostly the nutritionist. And here we can see the removal of a large piece of that circular ring. As you see, I use a lot the hook. The hook is a very wonderful instrument if properly used. That's it.
This is another case. I will go forward. This is the visualizes. It's similar to the previous one, so I'm going forward. It's important also to have the idea of sparing the vagus nerve, because in sleeve we don't have such a problem, but if you have a band and you're going to perform an OAGB, you are going to have a remnant, and the remnant needs to empty properly, otherwise there will be some dilation, and it is the cause of pain and bad quality of life of the patient. So try to keep the vagus healthy, don't cut him. It's a good rule. The ICG, we haven't shown it today, it was not necessary, but if you are in doubt about the vitality, the vital capacity of the tissue to survive to our intervention, you can use ICG. ICG is able to show us like this in the top of the pouch, the good irrigation of the pouch. So with this kind of image, we can be sure that there will be less risk of leaks because of a tissue necrosis. Another critical point is the ease angle because of vascular issues, and we have that problem in sleeve mostly, but it can happen in OAGB, mostly revisional. And here you can check also that all the tissue except the staple line is green, and the oxygen and the blood is reaching that properly. Of course, if you have another improved version of ICG, like the Rubina system, the more advanced one from stores, that we have the older system, the previous one, we had that for a test, but we are not able to buy it yet because it's too expensive. Look, there is an area of hypoperfusion in stenosis, one of the previous that we have seen before. All the rest of the wall is very well irrigated, but here, if you put an anastomosis here, well, maybe it's not going to be a good case. So it helps us do the anastomosis above that more dark area, not below. Okay? And trimming the pouch is also important to keep in mind that we need to keep the pouch straight and try to get the same amount of anterior face and posterior face in order to avoid torsions of the pouch, because torsions are the reason for problems, stenosis, functional stenosis, vomiting, nausea, and of course, reflux. This is very important in that higher part. Look, here we could cut here, but I checked the posterior face, I fix a little bit, I pull more, and I could get a complete piece of trimmed gastric pouch. Again, using SimGuard, that is good, except about the price. Don't forget to have black magazines with you. They are important. In some cases, even a green cartridge can be short. You need higher staples for some situations in revisional surgery. So please don't perform revisional surgeries without having black cartridge. It's an advice. There are different proposals for buttressing materials, but the one that we have found more properly is SimGuard, although it is expensive. We know that it avoids the hemorrhages and the hemorrhagic complications, but we don't know about leaks. There are no evidence in the literature that it can avoid leaks, but probably it will shortly. The staple line reinforcement we have seen today, but it's important. to try to invaginate the corner of the staple line, put it inside, and if you have a larger tube, you can make an invagination in the future. There are some discussions about which is the best way, invaginated or going through and through. Some people say that going through and through is not a real reinforcement. It's just two sutures in the same time, in the same place. But I would say also that invaginating is to create a two-plane suture. But I'm more practical. If I have to reduce a little bit the caliber of the stomach, I use invagination. Or if I have some torsion like here, with the invagination plane, we can somehow fix the torsion that we have got before, going far away from the staple line in the more like this, in the lower part, in the posterior face. So it's an important tool we should use also. What do you have more? Misfires. Someone told about misfires, but look at this case. Nothing was, everything was running smoothly, no problems. And here we have difficulty. We felt the machine was not advancing the blade properly. And look what we had. We found a bunch of failed staples. Something was wrong here. I don't know exactly, couldn't find exactly what. Maybe there was a clip that I couldn't see, but maybe just the blade found a staple in the beginning, and instead of cutting right away, far away from head, it just teared the situation. But for safety, I decided to cut again in the inner parts. I had margin for that, and even in the remnant, it's good to try to resect that part in order to avoid any kind of fixture. And of course, you can also resect and reinforce if you consider more advisable, and I've done it here in this case. So that's the same like before. Blue test is also important. Some people say, oh, I don't find it anymore, I won't do it. But from time to time, you have a surprise, and you have a tiny hole that you can prevent the leak, closing it with a simple stitch. Sorry, I couldn't find the case of those, but anyway, the blue test, we do it the same way, standardize it like we have seen today, and it works, it avoids leak. And the bowel measurement, some words about the way our measure the bowel. You have seen also today, but let me comment better now. See, this is the same case as the, sorry, this way. We go to the right angle, try to check the inferior mesenteric vein, and we measure the bowel in primary surgery up to 250 or 250 in super obese or mega obese people. And then we go to, okay, I'll tell you later. So this is the 2 meters. I asked the system to hold, in this case, at 250. That is what I think can be the biliopancreatic limb afterwards. And then I go to measure the second part of the bowel, what should be the common limb or the absorptive limb or the efferent limb. And you see 350, 4 meters. And we have found the minimum we have found was 4 meters of total bowel length. And in one patient recently, we found 10.5 meters, measuring 10 by 10 without mistake. This is the ileocecal valve. No. We found this, a MAC of the verticula that we decided to resect with a single cartridge, white cartridge. And we continued 550. look that we try to keep the vowel always in the right of our instruments, because if they go to the left, they will be in front of us and we are not able to see anything. So we decided in this place to put really at the 250, the anastomosis, at the 250 from the right angle, and that's it. And I suppose we have here a resection of the neofundus, like we have seen. Fortunately, today we had also that situation. That one was bigger. It was probably a kind of a technical mistake in this case. That is a big fundus, not dilated by pressure, but since the beginning it should be too much large. Again, with SIMGUARD, and looked at with Rubina, the ICG, we have also good images of the tissue. Look at the liver retains the pigment more time, and we have got more fluorescency. We are here waiting some time for the firing. There it is. And just for fun, we went to check, this is the bowel, the biliary tree, and look at that beautiful image of the biliary tree with the Rubina. And that's it. Those were my clips for you. Any questions or comments? No, no comments? Just a few people with us. Livia, are you there?
Yes, I am. Yes.
Where are our attendees? They were frightened with us.
Yes, I think that someone has to be to the operating room, and I don't know the other one. And Professor Musella is trying to be with you, but he has some problem to enter to the platform. I don't know if Pedro is here with you.
Yes, he's beside me.
Okay, if he can try to authorize Musella to enter to the Zoom, to the room.
Fazer convite novo para o Dr. Mário Musella. Okay.
Okay, thank you.
Right.
Paolo is here, also Fusia.
Yes, Fusia is. Pier Paolo also, and Massimiliano also. Mario Musella. Musella. Come Nutella. Mario Musella.
I don't know if I can give the email of Mario Musella. It's mario.musella@unina.it.
Musella with two L's.
Yes,
Mario.Musella
with two L at unina.it.
Unina.it.
Já está. Já está. Doutor, deixa estar. Está aqui. Vais passar aqui, não é de entrada. Já está aqui. Já está cá 10 minutos. Já certo. Não sei a resposta.
Hi Mario, how are you doing? Okay. Okay, we have just finished our work, but we are waiting for you. Don't worry. Okay, and we have sent another invitation right now. Okay, see you. So he has a problem, but with the Zoom account and is redoing it.
Yes, I think he has to refresh because probably there is some issue about.
I hope that we can meet together in Naples. Is there any scheduled date for that, Livia?
Yes, we perhaps the closing event is 18 of February.
Okay.
And in October, there is just one event in Israel at Sakran Hospital, but just for Israeli people, participants.
Okay, good.
And in Naples, all the teachers are coming, all the guests, also Professor Shikora, and everyone that was involved in the masterclass.
Yep, that's what was scheduled before.
Yes.
Right. So tell me something, because we had 5 teams, okay? We had 2 teams here.
Yes.
Has been in Catania last week, right?
Yes, in Catania. If you want, I can share the teams. If you like, I can share the file of the teams.
Yes, please. It would be interesting to see.
Okay, okay. So, ce l'hai tu aperto, Luci? Okay.
So, and what about you, Pierpaolo and Massimiliano? Are you tired of webinars?
Okay, here you are. This is the first topic, primary surgery, that we organize in very, I think it's November 19, yes. And technical variants in Lisbon at your clinic at February 2020, and in Catania, but I don't see, just a moment, because I think there is some, okay, okay, here we are, sorry.
Better now.
Okay. 15. Okay. Now it's better order for topic, because we did some change. I don't know why. E per quale revision? No, facciamo per primary. No, secondo me revision name è l'unica cosa. Ok. Non va. Ok. So someone has to do Naples with this topic, with technical variants, because just Francesco Greco has to do this one, also Jonathan Lessing, and Adolfo Renzi and Luca Sessa. They cannot do the technical variants.
Vale.
Okay, but I think together with the closing on February, we can try to do in presence the last one.
Yeah, sure.
Training. Okay, I see Mario.
Hi, Mario.
Hello. How are you doing?
Fine, thanks.
Hi, no thumbs up.
Congratulations.
¿Qué tal? ¿Cómo están?
Gracias, muy bien. Contentos con tu victoria sobre la Inglaterra.
Bueno, tras de Portugal, Italia. Perfecto.
Sí, perfecto.
Well, first of all, thank you for being here. I had quite a busy morning, so I could not connect, but Livia told me you made an extraordinary job and you gave a great surgery, and Octavio made a great presentation. So thank you very much for being part of this educational project. And well, I imagine I was listening to Livia that probably already gave to all the participants the dates for the following meeting, and of course we are trying to arrange all the following meeting in presence. But as you know, we are still facing the COVID problem. So let's see what happens. Possibly we are going. Livia, please confirm. But it is scheduled. The next meeting is scheduled in Israel. I remember it would be in October. Is correct?
Yes, in October. Yes.
Perfect. And of course, we are trying to arrange also the Napoli meeting. We are still deciding. We're still talking about if well, Napoli should be also the closing event. So we are trying to arrange it. We still don't know if we are going to do all in the same 2 days or doing before a web event with some surgery and then making the closing event with all the faculty and all the attendees in presence. It should be in February or at the end of January. We'll see, because it must be in the next year for the COVID restrictions that J&J had. So well, we're still deciding this. And well, I hope that all the attendees, I see Dr. Mesheri Fuzia. How are you doing? We met in Catania last week. So did you have a good feedback from this course? Did you have interesting lessons or tips or whatever?
Yes, thanks.
Okay, this is interesting, because my feeling is that this surgery is candidate to become probably the number one surgery in the next 2 years. We are reading all papers, all articles about how many troubles are experiencing people with the sleeve, and especially a lot of technical variants of the sleeve, the Nissen sleeve or whatever, that in my opinion is too tricky to be promoted and to be suggested to all patients. So I have the feeling that this surgery, I'm talking about the MGB-OHB, is scheduled, is probably predicted to be the most performant procedure within the next 2 years. This is my feeling. Maybe I'm wrong, I don't know, but it is growing. The numbers are increasing. So I think this is a very good procedure that will grow in next years. And of course, the aim of all people like me, like Dr. Ribeiro, Dr. Sacran, Dr. Carbajo, who are a little less, a little bit more experienced than the others, is to give the correct parameters to perform a right procedure. But sometimes, you know, in the past, there's been a lot of discussion about this procedure because probably some surgeons, very good surgeons, I mean, but probably trained to do a Roux-en-Y gastric bypass, for example, they did a patch that was too short, and this could lead to some problems, some issues with bile reflux. There's some important key steps that have to be followed to do the procedure in the correct way. So this is the aim, this is the objective of this school, this educational project. And to finish my salute to you, to finish is, I think this is interesting. We are scheduling with Rui, with Nasser, and with even other colleagues from Northern Europe or the MENA, the Middle East and North Africa area, a new edition of the masterclass that is predicted to involve all these countries, so a larger version of this educational project. And this should start in the second half of 2022. And well, this is to confirm that this procedure is growing in number. So that's all. And has been a pleasure by my side to meet you and having the chance to say goodbye to you all. And well, I wait to see you all in presence in Napoli, of course, at the beginning of 2022.
Okay, completely agree, Mario. Hopefully we can do that. And thanks by your presence. It's an honor for us to have your participation.
It's my pleasure and my honor being with you, Rui. You know, I'm serious. So,
and my thanks also to Livia and the technical organization and to the technical company that supported us, and of course to my friends here and to my friends there, like Massimiliano, Per Paolo, Fuccia. Thank you by your participation. We were just a few, but very good, and I hope that you could enjoy this session in the end. So thank you so much. And
thank you.
Bye bye. See you all.
Thank you to Pedro. Everything was very good and very good job. Thank you.
Thank you so much. It was a pleasure.
Ciao. Un abbraccio forte. Ciao.
Bye bye.
Bye.
Oh. Okay.
Fatto sligar tu.